नहीं नहीं, सॉरी, डैडी पी के बोले।
দশটা মনে এটা কত দিচ্ছে? 10 আছে দেখো তো। হুম, হচ্ছে এবার আমার ভালো করে। না, তখন কোথায় ছিল সেটা তুমি কি দাও তুমি? যখন ওখানে ছিল ওটা কি দাও?
sponsor of this scientific event called ENT. Before I go further, I will take just few minutes to introduce Lupin. I'm sure all of you know Lupin, but there are some facts and figures probably are not known to most of you. So Lupin is today a multinational company. When it comes to our global ranking in generics, we are the 10th largest company among the generics player. When it comes to Indian market, all the companies who are operating from India, we are the fifth largest Indian pharma company. In US, which is the biggest pharma market of the world, we are the third largest company by prescriptions. And in Indian pharma market, our ranking is sixth as per the latest IQVIA data. In South Africa, in the generics, we are again the fourth biggest pharma company in terms of prescription share. Now, Lupin also invests a lot of resources in research and development. 10.3%, approximately 10% of our revenue goes in R&D. We have total 15 manufacturing sites across the globe, which you can see across the continent. And out of these 15 manufacturing sites, 12 sites are in India. And we have also 7 research and development sites across the continents in respiratory and particularly in asthma. We are the second biggest Indian company. We also have very strong presence in CNS, in anti-infectives, including anti-TB, cephalosporins. Plus, we also have a very decent presence in GI therapy and in orthopedics. So, in short, our Indian pharma markets, Indian business size is approximately 6,000 crores. Our market share is approximately 3.5%. And when it comes to our growth, CAGR, we are growing at a rate of 11%, whereas the market is growing at a rate of 9%. Now, when it comes to Lupin as a company, we have our presence in almost all the therapy areas. We have our presence in total 23 therapies, from anti-diabetic to vitamin, mineral, and nutrients. In India, we are one of the largest company in terms of our sales force. We have 7,000 people who are working day and night to take care of the patients through doctors. So we have 7,000 field force who are working across all geographies, whether it is metro, class 1, towns, tier 2 towns, rural market, everywhere Lupin has its presence, ground presence. Lupin is also one of the favorite companies of the multinationals. We are very strong in patented products, in licensed products, because most of the multinational giants, they want to work with Lupin in India. So we have tie-up with Lilly, Novartis, Boehringer Ingelheim, Vyford, Fidia, and several companies in various therapeutic segments. We have also received so many accolades and awards. We have received the Indian Pharma Leader Award 2020. The chairman of our company, Ms. Vinita Gupta, she is India's one of the most powerful women as per Fortune. We have also received Green Tech CSR Award. We have also received 6 gold and 1 silver awards in quality forums. And we have also got the award of Pharma CSR Program of the Year by Government of India. So this is all about Lupin. As you all know, today this program is happening across the country. Almost 3,200 ENT surgeons has registered for this program. We have the physical meeting happening in the 7 largest cities of our country: Bombay, Delhi, Chennai, Hyderabad, Bangalore, and Pune. And in rest of the places, the ENT surgeons will be watching this program through the Zoom link. I now take the opportunity to introduce the who's who in the field of ENT, the faculties, the course directors, the speakers. Okay, first I will introduce Dr. Renuka Brado. I'm sure Dr. Renuka Brado does not need any introduction. He is the professor and head of the Department of Head and Neck Surgery, LTM Medical College in Mumbai. Thank you so much, madam, for helping us to to design this program and to design the entire course. And for all of you, ENT Live is not only a one event program. It will be a series. Every 3 months, there will be a program under Madam throughout the year, and we will continue this program for the coming years also. So this is the first series of season 1 of ENT Live. So may I request Mr. Dhiren Panda to, honor Madam Renuka Brado. Bombay is the nodal center of this program. The speaker and the faculties, they are in Bombay, and it is getting relayed to all the locations across the country. So today's star speaker plus panelist is Dr. Nishit Shah. Thank you, Dr. Shah, for agreeing to participate in this meeting. Again, I will request Mr. Dhiren Panda to felicitate Dr. Nishit Shah. So Dr. Nishit Shah also doesn't need any introduction. One of the celebrity ENT surgeons. He is a senior consultant and skull-based surgeon of Bombay Hospital, Bombay. Now I will introduce the other panelists. So we have with us in Bombay today, Professor Vivek Sasindran. Again, all these panelists or faculties does not require any introduction. So Dr. Vivek is from Pushpagiri Medical College, KM Cherian Institute of Medical Sciences from Tiruvalla, Kerala. Now, the second panelist of today's program is Dr. Gaurav Medikari. Dr. Gaurav Medikari is from Bangalore. He is the co-director of Medikari Super Specialty ENT Hospital. Plus, he is also associated with the skull-based surgeries of HCG group of hospitals. Thank you, Dr. Medikari. Thank you so much for being with us for today's program. Now I will introduce Dr. Hetal Patel. Dr. Hetal Patel also played a very important role in designing this program along with Madam Brado. So thank you, Madam. So Dr. Hetal Patel is also the professor and the head of the Department of ENT and Head and Neck Surgery from KM Hospital, Bombay. Thank you, Madam. Now, as I said, we have 6 other satellite centers across the country. So Dr. Snehashish Burman will be the moderator from Calcutta. Thank you, sir. Thank you, Dr. Burman, for agreeing to participate in this program and to moderate the Calcutta meeting. We also have with us Dr. Raghunandan in Chennai. Dr. Raghunandan will be the moderator in Chennai. Then Dr. Deepak Haldipur and Dr. Gayatri Pandit will be moderating the Bangalore group in Bangalore. And we also have with us Dr. Devinder Rai in Delhi, Dr. Megnath in Hyderabad, and Dr. Neelam Vaid in Pune. So with this, we will now roll out the program. And now I will invite Dr. Renuka Brado to come on the stage and to take the meeting forward.
Good evening, ladies and gentlemen. Can you hear me at all centers? Okay, I'm assuming that you can hear me at all centers. At the outset, I'd like to thank Lupin Pharmaceuticals for taking this initiative and inviting me and Lokmanya Tilak Municipal Medical College and General Hospital, popularly known as Sion Hospital, to curate this meeting and the opportunity to invite some of the leading key opinion leaders in the country today to take part in this meeting. I'd like to thank all the faculty, Dr. Nishit Shah, Dr. Gaurav Medikari, Dr. Vivek Sasindran, Dr. Hetal Patel, Dr. Deepak Haldipur, Dr. Gayatri Pandit, Dr. Megnath, Dr. Neelam Ved, Dr. Devinder Rai, Dr. Snehasis Burman, for taking out their valuable time to be with us through this entire meeting. As Lupin said, I hope this is going to be the first of a series, and we will be bringing you subsequently the other specialties other than rhinology as well. Let me just briefly take you through the timeline of the program. We're going to begin with a lecture on radiology of the paranasal sinus and skull base by Dr. Nishit Shah. After that, we will have a brief question answer session. We plan to keep the question answer session at the end of the program. Then we had a e-poster competition for all the residents, and 3 of the top prizes were selected, and these residents will then have an opportunity to present their poster at this meeting. Following that, there will be a panel discussion on ENT, OPD to OT to OPD. We are talking about pre-operative and post-operative care in rhinology, in fist surgery and skull-base surgery. And subsequently, we will have expert comments from each of the centers, the moderators from each of the centers. And then the satellite centers will de-link, and they will continue with the question answer session and discussion at each center separately, which will be convened by the moderator of that center. So I look forward to a very productive and fulfilling evening. I'd also like to make one more statement, and that is that whenever I go for a program or I curate a program, the first thing I ask is, what is the target audience? Who are we really going to be speaking to? And when I asked Lupin what was their vision of this program, they told me that we are keen to target the younger doctors in ENT specialty, those in the first 3 to 5 years of their practice, and also postgraduate residents as well. And so we've curated this program to deal with this target audience. We're going to talk about issues which I hear these questions at every conference that I go to. And so this time we're going to make sure that we keep this program targeted to this audience. And once again, thank you very much, Lupin. And I look forward to a wonderful time of interacting with all the faculty. Thank you.
Yeah, I'm going to put this off. Yeah, hello. So good evening to everyone, and a very big thank you to both Lupin and Dr. Renuka Bradu for this very kind invitation to speak to not just to you, but to apparently many centers across India. Can I cue this off and just get echo? Yeah. So the brief for today is to speak on radiology for the skull base and PNS. Now, many of you or most of you are, of course, familiar with CT scans. So I thought we'll spend a little more time on MRI, where everyone's a little more hesitant and a little more wary of looking at the scans. Also, I'm going to do a little bit of skull base before we go to PNS. Again, today, I think there's a lot of excitement about skull base surgery, and all the youngsters want to get into skull base. So this is just the first step, just to get you familiar with what the skull base looks like. So when we look at CT scans, of course, perfect for sinus disease, and you can't do sinus surgery without having a CT scan. If you have tumors, then you're going to add contrast. And it's the roadmap, not just for sinus, but even for skull base. And it took us a little time to convince the neurosurgery people that you can't just work with an MR. You have to have a CT as well. You do get a lot of additional information. MRIs are very good in PNS when you have tumors. If you want to differentiate fluid from or cyst from solid, and to understand the relationship of vasculature with pathology. And of course, for any complications of sinus disease. So if we look at the three things, right? CT, MR, and contrast, and you look at IBM, which is basically inflammation, benign, malignant, and I'll add an F to fibrous and bony later. So if you look at CT scans for inflammation, you're basically going to get remodeling and erosion. With benign issues, you're going to get more of expansion. And with malignancy, you're going to get more destruction on CT scan. On an MRI, you're going to see inflammation bright, except in the case of fungus. For benign, it'll be more an intermediate signal, whereas with malignant, again, it's more, we'll come to that, more heterogeneous as compared to more consistent or homogeneous with benign on contrast. And inflammation like an abscess, you just see more contrast on the periphery. Right, so again, just the same thing. When you're looking at T2 and you're going bright to dark, you're going to see inflammation, benign, malignant, fibrous, bony to dark. When we talk of DWI or diffusion weighted images, we're looking at restriction of the. So the less the movement, the brighter your images, right? And I'll explain to that in a moment. Contrast, we just mentioned, periphery for inflammation, homogeneous for benign, heterogeneous for malignancies. And on bone windows, you see remodeling inflammation, more hyperostosis and expansion on benign, infiltration and destruction with malignant and bony lesions. So let's look at nasal tumors, right? We'll do sinus last if you have time. And how does that help with bony tumors? You see intralesional calcifications. A very typical example is inverted papilloma, where you're looking for a little bit of hyperostosis at the points of attachment. It tells you, one, this is where you need to drill, you need to concentrate. And two, also it takes you towards the correct diagnosis. But you also see a number of other benign issues. Malignancies, you'll see more destruction. And with round cell tumors, which are the majority of things, you may have invasion. Benign lesions, we mentioned, will be expansion. And in any tumor, you want to do contrast. Today, not necessarily we always do CT contrast. We may do CT with MR contrast. But we do have contrast at one of these two modalities. And MRI, again, we're talking of nasal tumors, is far more information than a CT. It helps you characterize the type of tumor you're dealing with. It gives you, it may even give you a diagnosis of tumor just on pathology, because each tumor responds differently to magnetic resonance imaging. So we're looking at T1, T2, and we're looking at various other imaging spectrum. But it tells you what is tumor, what is obstruction. So you have behind the tumor, you have sinusitis, which CT sometimes just looks all the same. It tells you if there's invasion into the orbit, into the dura. Do I need to now plan much bigger surgery, or am I easy if there's no dural involvement? So let's take a step back and just understand what MRI is all about, right? So with MRI, you have this big magnet that is trying to align your water particles, your hydrogen atoms. So what happens is when you get this RF wave, you get this pulse, there's disruption, and all these atoms then have to come back to their normal position. And so we're looking at the speed of the pulses and how quickly they realign, and also at which in this cycle, you're taking your scan images. So when they do this movement, they're emitting energy. This energy is converted on the gray scale. So you see something's bright, something's gray, something's dark. And that's what you see on your images. Maybe in future, we'll have it in color. And the way that things are moving, I don't think it'll be very far. So T1 and T2 are your prime modalities on MR, right? So basically with T1, you see more dark as in CSF, and you see brighter CSF. When you're looking at head, your first instinct is to look at the CSF in the brain. Right? It's T2, if it's dark, it's T1. We're also going to be looking at stir, flare, and restriction. So we have these two things which are important in MR, TR and TE. Repetition time is between each pulse. So those of you who had experienced an MR know that tuck, 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 tuck in your head. Okay, that's your successive pulses. And then the time between the recovery of the pulse, of each pulse, and the receipt or when you're taking your images or shots. This determines your two times. Generally speaking, not necessary. T1 is short, TE and TR. T2 is longer, TE and TR. And hence you get different images. You can further play with this, right? By changing these two things. So if you talk of diffusion weighted images, basically when you do these things, water molecules in your body are moving. They move much faster extracellular, slower intracellular. If it's very dense or ischemic, that movement is less. If that movement is less, it'll appear brighter on your imaging. If there's quick movement, it'll appear darker. Like you see in blood flow, right? This quick flow, so you get a void. So that's what is basically checking the restriction. So more restricted, the brighter the images. Okay. And also tumors will have their own apparent ADCs or apparent diffusion coefficients. And this gives you information about each tumor. So a melanoma will look very different from a lymphoma on when you do DWIs. And so a good radiologist will be able to tell you even before the biopsy, likely to be this. If it's likely to be lymphoma, just do a small biopsy, send for fluorescein and sit on it. Wait for the report. You don't need to do anything more. Right? So it's very important to get this information. Also, it tells you about the spread of tumor. What is flare? So fluid attenuated inversion recovery is basically that you're going to have CSF, which is dark. So we want to use flare more in the brain. When you want to see pathology distinct from CSF, then you're going to use flare. And stir is short, either tau or T1 inversion recovery, where you're doing fat suppression. So you see pathology different from fat. So very good like orbit or pterygopalatine. So when we were having mucor cases all over the delta time, this is what we were using, right? You see orbital invasion, you see pterygopalatine invasion to separate it from fat. But more so, not so much with fungus, but more so with inflammation. Because inflammation is bright, fat is bright. And angio is useful again. And we talk now in terms of skull base and not in terms of ischemia. To evaluate major blood flows, to distinguish sometimes an aneurysm from a pathology, right? And then, of course, if you're using it for navigation, it's very useful. Okay, so from this generalized talk, let's talk of specific things in the skull base. So we look at the cella. So when we are doing scanning for the cella, it's obviously, of course, T1, T2, but you're also doing post-contrast T1, and you're doing flare, gradient imaging, diffusion weighted, and post-contrast images. So all of these are adding to your field and to your information. Important to note is FOV, which means you're focused on the cella. You don't have the whole head, you don't have the whole brain. So you have a nice magnified view of that cella. Dynamic contrast is also important because the anterior pituitary picks up contrast quickly. The tumor doesn't pick up quickly. So if you have a small, like a microadenoma, it's going to be dark, whereas your tumor, your normal gland is going to be bright. Again, not easy to pick up unless you do this sort of enhanced check. Okay. So for the pituitary, right, your normal pit is going to be iso-intense to gray. And when you use contrast, even in a large tumor, you should be able, in most cases, to see where the normal gland is. So for example, this is a very large tumor. You see areas of brightness, areas where there's cystic degeneration. You see the carotids, again, represented as voids here because of the flow void encasing, but you do see this rim here, and it's always prominent when you do a contrast, that you see this. And when you have a smaller tumor, the aim of surgery is always to try and preserve the normal gland function, whilst you want to remove all the tumor, right? So it's good to know where the normal pit is. Also, the posterior pit, and this is again very useful, is often on a sagittal scan on T1. You'll see the pituitary, posterior pituitary as a bright spot. So again, it tells you when you have largish tumors where your pituitary and your posterior pituitary, what controls a lot of your hormonal function, more important to save than your anterior gland. So your microadenomas we mentioned is poor and delayed enhancement, which is why it appears darker. Apoplexy can appear. So one of the quick indications or necessary indications for surgery is apoplexy, because you don't know when that patient will bleed again, and suddenly you have patients who are unconscious or have altered consciousness, and you see that they are hyperintense on T1 and hypo on T2. Okay. So let's look at a few images here. You see a darkish area on this right side, whereas a bright area on the left side. So this bright area is post-contrast is your normal pituitary gland, and the darker area is your microadenoma, unlike other tumors which may pick up contrast more and appear brighter than the surrounding areas. You see also the stalk and the optic chiasm. So you want to see the surrounding structures as well, right? You see the bright spot on the sag T1. And on axial, sometimes with largish tumors, you're not able to see clearly where the stalk is. Or for cranios, you want to try and preserve the stalk. It's good to look at axials and follow it from the infundibulum or the third ventricle. Again, just another example of how the same tumor looks different on CT scan T2 and T1. This is post-contrast, where you, on a scan, on a CT, you see different things, right? You see pneumatization of the sphenoid, you see erosion of bone, you see how the skull base lies, you want to see sphenoid cells, you want to see the intersphenoid septation, how it deviates to which side, and you want to see for DNSs, spurs, if you want to take a Haddad flap, which side do you want to go on. T2 MRI is gold standard for any intracranial pathology. You can't function without an MRI, which is why it's so important. Even 4 years ago, I was speaking to Amin Kasam, and he said that in the near future, MRI will replace CT scans, even for sinus pathology, because it gives you so much more information, and we will learn how to use MRI to see bone as well. So that's why we must focus on learning more about MRI, because it gives you more information, whilst not forgetting, of course, that CT scan is also very valuable. Okay. So hypophysitis, you get different types of hypophysitis. You can get granulomatous or, sorry, let's take this out. Let's go back. So there's a very big difference between a normal gland, a hypophysitis, and a tumor. And whilst a hypophysitis can sometimes mimic a pituitary macroadenoma, it can be irregular like you see here, but generally it's homogeneous on contrast. You don't see a normal gland separate from it. And again, the important thing is that the stalk will be thicker and enhance more. So you're always looking at that stalk to see if it's likely to be hypophysitis, to also differentiate it from something like a Rathke's cleft, which will be similar to this. Meningiomas will appear hyperdense on CT, will have some areas of hyperostosis and some areas of erosion. Very typical. Even when you operate, you'll see that the bone in areas is thicker, is granular. The dura looks different. And on an MR, you'll see typically a little tail. You see a tail. The lesion has a little tail to it. Very typical of a meningioma. And of course, with any lesion around the sella, you want to first try and locate the pituitary. If you see a normal gland separate from the lesion, you know straight away it's not a macroadenoma or not an adenoma. It is something else. So look for a normal gland. You see a normal gland here, and you see the meningioma sitting on top here. Aesthesios, heterogeneous. Of course, you will see the interplane between at the cribriform level, there is erosion. But you see again on CT, not much information. But you look at the MR, you see immediately it involves the olfactory bulb on the left. It pushes the septum, but there is a plane here. And it goes down and involves the orbit, but doesn't involve the muscles. So now I know this is a restricted tumor. All I need to do is do a small craniotomy to get that olfactory bulb out. I don't have to do a big surgery for this patient. As again, something like this, which has a big intracranial extension, typically you will see these peritumoral cysts within it. When you see this kind of picture, you know it's more likely to be an aesthesio. Cranios, again, are complex. More commonly seen in the younger age group. They are around the stalk, right? They come from this, they develop from around the stalk. So they can be in front of the stalk, they can be retroinfundibular, and you need to see its relationship with the optic chiasm as well. But typically, the big part of it is cystic. But you will have calcification within it. It may be on the periphery, maybe as a small chunk at the bottom, but you will see calcification. This is where a CT scan comes into play with cranios, because you don't see that calcification easily on an MR. So always have two things. When you have this sort of cystic lesion in a young patient, always look at a CT and look for the normal pituitary gland separate. Chordomas can come anywhere, but here we're just looking at clival chordomas because for us is the commonest area where our chordomas come in. And you'll see osteolytic destruction of the clivus. And though it was thought that you get calcifications, we now think it's more likely to be remnants of the bone which has not been destroyed within the tumor itself. Almost always they lie extradural. So you must look, there will be some aggressive chordomas which have made holes in the dura or have gone intradural. But usually chordomas are extradural. But when they do go intradural, so you see here it's pressing against the brainstem. This is a different situation. And these cases, where lower the defect, the more difficult to repair, the higher the pressures. Higher the defect, cribriform area, easier the repair, lesser the pressure. So your whole mental preparation is different. Okay, let's come back to the nose. So just to reorient you with the IBMF. So let's look at fibroosseous. You have this very dense white appearance on CT with osteomas, more ground glass with fibrous dysplasias, and with aneurysmal bone cyst, you see again a third different picture with this sort of intralesional cyst in there. Staying with tumors in the nose. So with papillomas, you'll get hyperostosis. We spoke of this. Though you have a typical location in the maxilla ethmoid area, with that area most likely, we've had papillomas isolated frontal sinus, isolated sphenoid sinus. So it's not uncommon that it's outside this area. Melanomas will appear hyperintense on T1, lymphomas hyperintense on diffusion. So there's more restriction. Anesthesio, as we mentioned already. So papilloma, just an example, they also have what we call a cerebriform pattern on MRI, which means it looks like a little brain within the tumor. Okay. And then you have that calcification, sometimes even within it, but also at the points of attachment. This is just an example of an orbital hemangioma and how it looks. And you want to differentiate it from the muscles, from the fat planes, and see where it lies in relation to the muscle. So, for example, this hemangioma is in a very favorable location between the inferior and medial recti. So, and I have my corridor there between these two muscles to get this thing out. So I must see what, and now you know that orbital surgery, endoscopic is 360 degrees. You can approach it from any direction. So it really depends on where it is in relation to the muscles and the optic nerve. If it is not medial to the optic nerve, you can't get it endoscopically through the nose. Then you find another route. The reason we have this hemangiopericytoma is to show you typically this, what you can't make out on a CT scan, is you see this big lesion here in the nose, and laterally in the maxilla, you see a fluid collection. So this tells you without any ambiguity that this is retroobstructive sinusitis. You know your tumor is contained to the nose. You see a little plane here between tumor and the sinus. And now when you go back to the sinus, you see a little thin line there. You see a little thin line there. I'm not sure if it's easy on your thing, but I think it is. And it tells you that your maxillary wall has been pushed in. That this tumor is now entirely in the nasal cavity. You don't have to do any big external surgery. You don't even need a Denkers. You can do this endoscopically. So it gives you so much more information. Of course, the melanoma we spoke about bright on T1. Lymphomas have their own characteristic picture. And we'll come back down to the nose. Okay, so this patient was brought to me by a colleague saying, very difficult case. The whole skull base is gone. Do you think you can do a repair in terms of meningoencephalocele? And I'm looking at the scan. I'm saying, CSF looks different. This looks different. Have you done an MRI? He's saying, yeah, I've done MRI. I said, show me. And this is what you get on the MRI. Now you see on the MRI instantly, you see CSF is dark here. This is bright. This cannot be CSF. It cannot be a meningoencephalocele. So what is a very difficult operation now becomes a very easy operation. You know, all you need to do is open up the sphenoid wide, surgery is over. Even though the skull base is deficient, you just have to be careful. You don't need to reconstruct anything because your dura is going to be intact. You're not going to have a CSF leak. You just want to marsupialize. In fact, you don't want to put anything there because you want the secretions to drain out. Okay, so another example, now we talk of CSF leaks, right? We have gradually migrated. So initially we were doing CT cisternos as the gold standard for everything. But we did have some patients who could not do a lumbar puncture or were scared of a lumbar puncture. Or some people who are not good at a lumbar puncture. So we are not getting good results. So we've now gone slightly away from a CT cisterno to using more a CT plane with an MR cisterno. And we find that this is almost the same in terms of success rate in detecting where your leak is, right? So for even in this difficult situation, so this was a patient pre-op. This is post-op, right? So this patient came to us post-op. You can see that the turbinates have been pretty much chopped off and there's enough disease still remaining laterally. And this patient had now a watery discharge from the nose post-op and came to us with this. So on the MR cisterno, you see a nice clear flow from the lateral cribriform, which is not difficult or which is difficult to make out on a CT because of the presence of disease. And sometimes even on an MR, it's not easy, MR cisterno. So this is one of the situations where if you have a lot of inflammatory disease, I might go to a CT cisterno if I'm not very clear cut on the MR cisterno. But otherwise, in most cases, CT with an MR. So we'll go now to sinus. Tell me when we have 5 minutes. Huh? Sinus disease. And typically when we look at AFS, when we have AFS, most people, even today, make the tragic error, I call it tragic, of doing a limited CT scan PNS. I think it is a starting point of making your mistake in doing surgery, FES surgery. Because on limited coronal scans in one window, you're not getting enough information. What are you trying to save? 300-400 rupees for not getting additional films. What are you losing? Information that can result in residual disease, information that can cause a complication. Which is more expensive? Getting 3 films or a revision surgery? It just doesn't make sense. Okay. Now, if you want to see AFS clearly, you need a soft tissue window. You cannot see it clearly on a bone window. You see double density, you know immediately what looks like a big tumor on a bone window is just AFS. Again, extradural disease, give a little bit of steroid, don't rush into it, operate at peace. Of course, you're going to take consent for all these things, but you can be a little more relaxed about it, right? Your single sinus involvement, you know, it's more of a fungal ball. Inflammation, you get the whole range, right? From just a sinusitis to a chronic CRS with early polyps to a full-blown polyposis. And again, you learn over time to sort of distinguish what looks more like fluidy, what looks more like an acute sinus, what looks more like a chronic sinus, what is now becoming a CRS with polyposis, right? Typically, what you see here is an early polyposis disease, right? And then you have a full-fledged. So again, you can, depending on your experience, what the patient wants, using CT scans, decide whether you want to go medical treatment, do medical pre-op and surgery, or of course, you 100% need surgery in discussion with the patients. So we come down to FES, right? Now we come down to basics. So with FES, we are looking at the scan 3 times. Our first reading of the scan is just anatomy. We're just looking at anatomy. Then we're looking at pathology. This is pre-op, not initially when the patient comes to your OPD, of course, you're looking at pathology. And 3, we're looking at risk areas. What are your risk areas? What are your common complications? Bleeding. So you're looking at anterior, posterior ethmoids and your carotid. CSF leaks, you're looking at skull base and your eye. Lamina papyracea, optic nerve. These are your risk areas. So once you do these 3 readings, you have a plan for surgery. That this is what I want to do in this sequence. And if possible, you have the plan in front of you when you're operating. You always have the CT scans in front of you when you're operating. It's never only in your memory. The important things when we look at a CT scan for sinusitis or for FES surgery, we're looking at all these different structures one by one. So a few things have changed from when we started reading scans 30 years ago, right? We were having only 5 millimeter axial scans to start with, then reconstructed coronal scans, not very good. We were seeing only pathology. Then we got better 1.5 or 2 mm cuts. We started looking a little bit at anatomy and we said first film, second film, third film. Today, I read my scans not film by film, but sinus by sinus. So I'm looking at frontal sinus drainage, then I'm looking at ethmoid sinus, then I'm looking at maxilla. So that sort of thought process has changed. So in the frontal, I'm looking at pneumatization, how big or wide. If the frontal recess is wide, I don't care if there are 100 frontal cells. It's going to be an easy surgery. If it's narrow, it's going to be a difficult surgery. But even though it's wide, you want to look at that cell structure. You want to see the drainage pattern and you want to tackle it accordingly. The most difficult sinus by far in your sinus surgery is the frontal. Then you want to look at, of course, the turbinate, whether the uncinate is very lateralized or is it sort of like a double turbinate sign, etc. Small ethmoid bulla means the orbit is more at risk, etc. So we continue with that checklist. You want to see your skull base. Not necessary both sides are symmetrical, right? One side can be higher, one side can be lower. You want to see, and this has happened to me once, that I missed that the skull base was sloping downward and I had a CSF leak in the posterior ethmoid because I went a little straighter. So there are many things to sort of look at, right? And we spoke of these 5 or 6 things that are important. So every patient who's going to get a FES surgery for me, not only do I need a triplanar scan with 2 windows, but I also need DICOM images. So I will always load those images on Osirix, Horos, if you have a Mac or an equivalent Windows software, and study this on these images. And I want to just run you through a little bit of this if I have 2 minutes. I don't know how I can change my window, but yeah, okay, great. So once you have loaded your images, you'll get this whole list of different images that you're on. You want to choose the series which has maximum images, which are the closest together, which is usually your axial cuts. Once you have your axial cuts, I can do what is called a 3D MPR. So I have all 3 images on one film, on one page, and I want to see it well. So let's magnify it a bit so that I have it clearly. And again, whilst I understand this reluctance to look at axial and sagittal cuts, because everyone's familiar with coronal, it's your plane of surgery from front to back. But the scan that gives you the maximum information is the axial scan. Axial scan gives you information that the coronal cannot. Also, sometimes you will see images on your coronal that looks like this, right? One eye is big, one eye is small. Sometimes it's completely off. So when I have this on my system, I can make sure that it's equal, it's proper, that my scans are in the true coronal plane. They are not oblique scans, neither axial nor coronal. So I make sure they are perpendicular to the hard palate. So now it's exact, all right? I can change my window if I'm not happy with it. So I can see exactly what I want to see. And this is how I learn my scans. Because if I put my marker here and I want to see what it looks like on this imaging, I can see what for example, the anterior ethmoid artery looks like here, right? You can see it on the axial running across. So I put it here and you see that it corresponds here and it corresponds here. If the maxilla, for example, right, you want to see the pterygo, let's go. So whatever it is, wherever it is, if you have an Onodi cell situation, you're not sure, where is it useful, right? Onodi cell, you're not sure, is this Onodi, is this sphenoid? I can put my marker here and see that it's just an anterior superior pneumatization of sphenoid. It's not an Onodi. Whereas this is the posterior ethmoid, right? You see it on the sat, you see it on the axial. Again, on coronal, it's difficult to know when your frontal ends and the supraorbital starts, for example. So you look over here, you see frontal sinus. You go back, you see it's going towards the supraorbital. You can change it here on the axial and see again the same thing. Let's look at axial and a few things what I would like to see on axial alone. And I'm doing this because to take you away from comfort zones, right? What do I see on axials that I don't see anywhere else? Okay, so when I'm coming from down, see very nicely the nasopharynx, exhalation tubes, fossa of Rosenmuller. Don't see that well on other scans. I see the walls of the mag, which you can't see on other scans. You see the walls of the frontal sinus, anterior, posterior, which you don't see on coronal scans. You see the whole pterygopalatine complex, right? Pterygopalatine fossa, the fissure, and the infratemporal area. You see your pterygoid plates beautifully on axial scans. If you come up to the sphenoid area, you see the Vidian nerves early, right? You see the carotid as it runs through the whole canal and up and forms the pliable part of the carotid. If you come up higher, you see the V2 as it comes up in continuity with the pterygopalatine. The intersphenoid septations. So all these things you can see even clearly if you look at this. This is the nasolacrimal duct. Just in front is the consonant process. You see it beautifully. You see the infilum. You can't see these things as well as you see on an axial on other scans. Sagittal scans have their own value. of the frontal sinus, of the lie of the skull base, onode, optic nerve, etc., carotid, as the whole way it runs. I want you to think differently with CT scans and look at it in a different way. Right, so let's go back to this, right? We don't have enough time to do that. So at the end of it, this is a form that I have designed for myself, where I fill up for right and left, septum, frontal sinus, maxilla, ethmoid, etc., what it looks like in each of these areas. I then fill up the risk areas, look at the pathology and what it affects with sinus. What is the type of pathology? It is CRS, AFS, polyposis, and then I have a plan. So I want this in front of me. So it's easy for me to refer to. I don't even need to look at the scans once I've gone through this whole process. Okay, I think our time is up. So to say thank you, we do have, for those interested, a very nice book on transsphenoid surgery, which has a whole chapter on radiology for the skull base. And that's why I've put Sonali's name, who's written the chapter in that book here, because a lot of this is her input, as well as a big thank you to my colleagues at Bombay Hospital, Dr. Devpujari in neurosurgery and Sujata in ENT with me. So thank you once again. I don't know if you have time for questions later. Okay. Do I do a stop share? How does it go? Done already. Okay.
Okay, 5 minutes of question.
Okay, Dr. Renuka is saying 5 minutes of questions if there are, otherwise we move quickly to e-posters. So anybody at any center? I think we'll give them a little time to think, mull, yeah. And we'll come back to you all once the e-posters are done.
Hello.
Sorry, we do one question from Pune. Okay. Yeah, Neelam.
Just unmute. Neelam.
Neelam, you're muted. Yeah.
Yeah.
Neelam, we can't hear you. So we'll do it after the next session.
Yeah.
So we get our...
Yeah. Hi, Neelam ma'am. Can you hear us?
Yeah, I can hear you,
Yes.
but
Thank you.
Okay, let's do two questions since you're here.
Okay, just a quick one. When you speak about CT cisterno and MRI cisterno, would it be also right to say that it would be advisable to do CT cisterno when you have active leaks and MRI more when you are suspecting a leak and not really sure?
To an extent, yes. An active leak, of course, will be picked up both on MR cisterno and CT cisterno. If you have multiple breaks, then I would probably go with a CT cisterno so that I'm not ending up repairing suspected breaks. And if there's a lot of inflammation.
Okay, thanks.
Okay, thank you.
Any question?
Yeah.
So we're going to take the question answers at the end of the session, at the end of the program. The e-poster competition was held across all.
If you have any doubt, any questions?
All medical colleges, and we had unbiased judges, specifically from none of the specific medical colleges. We had Dr. Narayan Jaishankar, and of course from Cooper we had Dr. Samir Bhargav. And both of them gave their marks independent of each other. And then we collated the marks together to see who comes first or second or third. So the first is Dr. Usha Tamali. Second is Dr. Parth Patel. And the third is Dr. Isha Jain. So I'm going to give them, since this is a platform for young doctors, we decided to give them their place in the sun. And so each of them will present their poster for 10 minutes. So I'll ask Dr. Usha Tamali to start, after which Dr. Parth Patel will speak, and then Dr. Isha Jain.
Good evening, respected teachers, seniors, and colleagues. I am Dr. Usha from the Department of ENT, Sion Hospital. Today, I will be presenting the topic of pterygopalatine fossa, a keystone area in disease progression and management of rhino-oculocerebral mucormycosis. As you may all know, mucormycosis is an infection caused by filamentous fungi belonging to the mucorale. It has many clinical manifestations, while rhino-oculocerebral mucormycosis being the commonest form of the disease. It has a high mortality rate of 90% associated with disseminated disease. There are many predisposing factors. Mainly, it was as you all know, uncontrolled diabetes mellitus is seen to be the most common underlying predisposing factor. During the pandemic of COVID-19, we could see a rise in the incidence of disease due to the uses of high dose of steroids for a prolonged period. The main reason for the disseminated spread of the disease is due to the angioinvasive nature of the fungus. Pterygopalatine fossa is an area where the fungus harbors and proliferates, leading to the spread to the all areas of its communications like in orbit and brain. We did an observational study over a population of 50 patients in a tertiary care center, that is Sion Hospital, over a period of 1 year. The main aim of our study being to analyze the involvement of the pterygopalatine fossa and spread of the disease. The objectives of our study were to look for the disease in pterygopalatine fossa through imaging modality and during the intraoperative findings, to analyze spread into the communicating areas, and to achieve complete disease of the cure of the disease and regular follow-up. The inclusion criteria for our study was all the patients who had clinical features and histopath suggestive of mucormycosis. Exclusion criteria being the patients who were not willing to participate in the study and where the pterygopalatine fossa was not opened during the surgery, and the patients who were required critical ill care. During our study, we did a clinical evaluation of the patient and we collected specimens for the fungal culture and KOH mount through nasal endoscopy. We did a CT PNS and MRI PNS imaging to see the extent of the disease. Coming to the treatment, we surgically debrided the patient, surgically debrided all the dead tissue till the fresh vascular tissue is seen, followed by medical management with antifungals like amphotericin till the tissue was negative for fungal culture. During our observation, we could see that most of the people with the disease belong to the group age group of 40 to 50 years, and there was an equal distribution among the male and female patients. Among our 50 patients, 32 patients had a positive history of COVID-19 infection, and diabetes was seen to be associated among the 48 patients or over 50. Coming to the regional involvement of the disease, nasal cavity was seen to be involved in all of the patients, while pterygopalatine fossa and infratemporal fossa were involved in 29 patients, while orbit and palate were involved in 26 patients out of 50. Among the 29 patients with pterygopalatine fossa involvement during the intraoperative period, we could see that 21 out of the 29 was showing necrosis, while 8 was showing inflammation. During our study, we could also see that by comparing the intraoperative findings and the imaging findings, we could see that MRI was more specific and sensitive in diagnosing the disease. Coming to the regional involvement of the disease and the involvement of pterygopalatine fossa, we could see that pterygopalatine fossa was almost involved in 96% of the patient with orbital involvement, and it was 100% with the patients with intracranial, infratemporal fossa and skull base osteomyelitis. And during our study, among the total population, that is 50 patients, 58% of the patients had the involvement of pterygopalatine fossa, and with the patients with locoregional spread, it was 96%. And regarding the outcome of our 50 patients, 45 among the 50 were completely cured, while 5 succumbed to death. Among the cured 45 patients, 6 of them had a sequel of osteomyelitis and ischiothrombosis. I would like to conclude by mucormycosis requires a multidisciplinary management for complete cure with the team of otolaryngologist, physician, neurophysician, ophthalmologist, and a radiologist. While and pterygopalatine fossa is a hive for the fungus to harbor and proliferate and causing the spread of the disease to the communicating areas, and the importance of addressing all the involved areas for the complete cure of the disease and to prevent the recurrence and further spread of the disease. Thank you.
Hello, good evening, everyone. I'm Dr. Parth Patel, ENT junior resident from DY Patel Hospital, Navi Mumbai. So today I'll be presenting a poster for frontoethmoidal mucosal revision surgeries, a series of combined approach management. So mucosal is a collection of mucus into the sinus cavities along with its desquamated epithelium that they develop when the physiological sinus drainage is impaired. So management of the frontal sinus pathologies remain a domain of concern despite of the technical nuances of the endoscope. Surgical manipulation in case of sinusitis, mucosals, and any space occupying lesions, despite good resection, can lead to failure due to scarring and stenosis of the ostium. So in this series, we present the 16 patients operated in a span of 5 years for frontoethmoidal mucosal. The cases we came across, even though diagnosed histopathologically as a mucosal, presented in varied fashion, and their operative findings differed as well. So in the method, we did a retrospective analysis of the 16 cases of frontoethmoidal mucosal that were presented to us over the span of 10 years. So these cases were diagnosed and surgically management with combined endoscopic and external approach as well as stenting. These cases were diagnosed and surgically managed with combined endoscopic and external approach with stenting as well. So this article overviews this demographic data, symptomatology, surgical finding, and post-operative complications, if any. All the patients were pre-operatively done contrast enhanced CT scan for better pre-operative evaluation and understanding the extent of lesion. Also for the evaluation of bone erosion and involvement of orbit and cranial cavity, if any. So all the surgeries were performed under the general anesthesia. The endoscopic approach was done with 0-degree scope as well as 45-degree scope. In the because all these cases were already a revision cases and previously done by endoscopic procedure. So in every cases, as per the landmark found, the mucosis was identified in the frontoethmoidal area. After that, we did an external approach. In external approach, a Howard leech incision was taken for the external approach. And we access the floor of the frontal sinus. Sorry, the floor of the frontal sinus is visualized. In some cases, the floor was already breached by long-standing mucosal. In any cases of difficulty in identifying the ostium, the sinus was probed endoscopically. After the external dissection and endoscopic approach together, the mucosal was identified, drained and debrided as well as per the pathology. After that, an irrigation was done, and we could see the drainage, the adequate drainage was there from the frontal sinus to nostrils. After that, the stenting was done. In the stenting, a silicone single lumen tube stent was used in all cases that were threaded externally from the floor of frontal sinus via external approach and guided into the nasal cavity. In the nasal cavity, it was then pulled and fixed to the ala of nose with 40 Vicryl sutures. The stent was kept in place for about 6 weeks for better drainage of the sinus and mucosalization of the outflow tract. The periosteum and skin were closed in layers. All the patients were followed up post-operatively with a diagnostic nasal endoscopy at 6 weeks, 6 months, and 1 year. As per the additional, there is their clinical course if necessary. So here showing is the pre-operative CT scan of the PNS showing the left one patient of a left frontoethmoidal mucosal. One second. As in a result, we could see we have performed 16 surgeries, which included 10 male and 6 female patients. All the cases were post-operatively confirmed case of mucosal with histopathologic examination. They presented mainly to us with actually periorbital swelling, proptosis, and the common complaint was headache. So all the patient underwent combined approach resection of mucosal with post-operating stenting as well. No, in this all the procedure, no major complications such as CSF leak or anything were encountered during any of the procedure. Post-operatively, the stent was placed in situ for about 6 weeks, after which it was electively removed. The shortest duration was 7 days. The post-operatively follow-up included nasal endoscopy, showed a patient ostium and no evidence of stenosis in the outflow tract. Post-operatively, lead scarring was seen in 2 of the cases, which was so mild, so no intervention was done. In the post-operative, 3 of the patient presented to us with some mild adhesions, which could go into the stenosis, but we removed the adhesions. So after that, and we put the stent again for 3 weeks. So after that, the patient were fine and they didn't have any complaints. So the post-operative follow-up included nasal endoscopy. The recurrence has not been encountered yet in any of these cases. Cosmetically, result in all cases were very good, and eye movement improved drastically. So I would like to conclude as the outcome in case of frontal sinus pathology, despite endoscopic advance, remain an area of concern for any sinus surgeons. It's complex, and because of it, complex anatomy, narrow pathway, and hindrance due to bony landmark for endoscope are varied challenge faced. Success rates depend on the formation of a wide enough ostium for adequate aeration and drainage of the sinus, preservation of its natural mucosa, and patency of the sinus outflow. And the long-term result of the patency of the tract we hampered due to the post-operative stenosis. So for post-operative stenosis, the stenting proves to be a very good option in frontal sinus recess surgeries to maintain its function, hence give the excellent post-operative result. Thank you.
Good evening, everyone. So my topic for today is factors affecting the frontal sinus surgeries. So my name is Isha Jain from Department of ENT from Sion Hospital. Everyone has this one question: why is it frontal sinus? As my colleague said previously, it's because of the variation of the anatomy. It is also because of the potential dangers around it. Medially, we have the olfactory recess. Laterally, we have the lamina, and on the top, the skull base. And also the drainage system of the frontal sinus, which is through the frontal recess. The main aims and objectives that we came across in this study is the outcome of the patients with improvement of the symptoms, which we did it through the SNOT 22 scoring system. We also saw the different endoscopic surgery approaches, how would it affect the outcome, and also the parameters in the good post-operative care and healing. The methodology, it was a single prospect place in a tertiary care hospital in a span of 2 years, and the sample size was 25. The inclusion criteria to ENT OPD with sinonasal complaints. It was also the patients who were about 12 years of age because of the frontal sinus development and the operation.
Why throttling? Occurring cross.
Hello, Mumbai. We're calling from Hyderabad.
Studied, as I said, most importantly, we studied through the SNOT 22 scoring system, where the patients would score out of 0 to 5 for their 22 symptoms and pre and post operatively. The pre operative CT findings and endoscopic findings for most all the patients, as we do, and most of the doctors do today, and also the intraoperative frontal glow and post operative endoscopic findings. The observations that we made, we'll start from basics. The demography with males and females were equally affected, and the age group that were affected were 25 to 50 in both the males and females. Symptomatically, the most common symptoms that we came across was the nasal blockage, whereas almost 2/3 of them had histories of allergy, and 30% of them were revision surgeries. We also had divided them according to the pathologies. The most common pathology we came across was allergic fungal rhinosinusitis. The other pathologies that we had studied were chronic rhinosinusitis with polyps, without polyps, sinusitis with osteomyelitis, and frontoethymoidal piosity. We also divided them according to the frontal recess cell through by the Kuhn's classification, where type 1 was the most common and type 4 was the least common that we found on the CT. The frontal sinus surgeries, we saw intraoperative frontal glow, where almost 90 to 95% of patients had intraoperative frontal glow. And we use different techniques like the open bulla and the intact bulla. Usually the intact bulla is the one which is preferred because it protects the anterior ethmoidal artery. But yet we did the open bulla technique, which was most commonly done because of the wider operating field. The frontal recess was mucosa line. So when we did surgeries, if we preserved the lining of the mucosa, it showed a very favorable outcome, almost 70 to 75%. But if we didn't do that, there was a 0% favorable outcome that we saw. With also the classification of the extent of the endoscopic functional sinus surgery, which is the most recent one, the type 1 was done for almost 14 patients out of the 25. The results that we got, the endoscopically, the middle turbinate, it was medialized in almost 81 to 83% of the cases. Axilla was fibrosed and the frontal recess patency. So if the frontal recess was mucalized in most of them, almost more than 50%. But if it would be edematous and polypoidal, but yet patent, we consider them as a favorable outcome. Then with frontal glow, as I said, intraoperatively, frontal glow was there in 90 to 95% of the patients. But when we followed them up for 3 months, we saw that it had been absent for 50 to 55% of the patients. But it did not affect the patency of the frontal recess. So it was yet a favorable outcome when the frontal glow was absent at 3 months follow-up. And also the SNOT 22 scoring system. We saw that symptomatically the patients were better. There was a decrease in the SNOT 22 score by the end of 3 months. We also studied the SNOT 22 score according to the compliance of the patient. So the good compliance was when the patient used douching and nasal sprays for almost 6 days per week, and poor was when less than 3 days per week. We saw that both of them at the end of 3 months were almost equal, but the speeding of the recovery differed. The one with good compliance had a speeder recovery. The conclusion is that the primary surgeries had a better success rate than the revision surgeries. Then the pneumatization of frontal recess cell also mattered, but it all depends on the meticulous dissection that the surgeons do. It depend. Then the both intact and the open bulla technique has its own advantages and disadvantages, but the outcome of the frontal sinus surgery did not affect on the kind of surgery that you would choose, the technique. The most important prognostic factor, as I said, was the mucosa lining. We have to preserve the mucosa lining of the frontal recess. And the frontal glow, even though it was absent, it was patent, the frontal recess. So it was just a reassuring sign. It did not actually matter on the outcome of the clinical improvement. And the compliance, as I said, it was just symptomatically speedy recovery, but at the end of 3 months. Thank you.
May I request Professor Hetal Patel to please do the honors for the person who got the first prize, Dr. Usha Tamali. May I request Dr. Nishit Shah to please do the honors for the person who got the second prize, Dr. Parth Patel. And may I request Dr. Gaurav Medicari to please do the honors for the person who got the third prize, Dr. Isha Jain. We now move on to the next part of our program, which is the panel discussion. May I request our panelists to please come on the stage. Professor Hetal Patel, Professor Vivek Sasindran, Dr. Nishit Shah, Dr. Gaurav Medicari. So most panel discussions we have are generally more concentrated on intraoperative videos, intraoperative findings, and how to deal with things intraoperatively. But I find that, in the course of various workshops that we've done, is that there's a large segment of the audience who really wants to know how to manage the patient preoperatively and how to manage the patient postoperatively, because this pre and post-op is what will, besides the surgery, make a huge impact on the results that you will have in your patient care. So we thought we'd have a panel discussion. As I can see, there are a lot of young, fresh faces over here. And I'm very happy that we have such a lot of young doctors here today. And I hope this proves beneficial to you. May I request the panelists to pay attention? Sorry about that cough, but we'll try and see that we can manage without it. Let's see. So the first thing that I'd like to talk about is maximum medical therapy. I'm going to, certain slides, I'm going to ask for the opinion of all the panelists. And for certain slides, I will just request a particular person to speak. Dr. Hetal, what is your take on maximum medical therapy? What do you like to give and how long do you like to give it? How early before the surgery would you like to start maximum medical therapy?
Before I decide for surgery, definitely I would make sure that the patient has been adequately treated medically in the form of medication. My preferred medication is start from amoxicillin. The next best is amoxicillin with clavulanic acid. And then if I have to give it long term, when I feel that, it could revert back, then I will go to levoflux group of drugs.
So I think for me, most of the patients that come have already gone through multiple courses of antibiotics. So you want to check with them what they have already taken. And then it's one of the fall between amoxiclav, quinolones, clarithromycin, and cefuroxime.
How often do you see diarrhea in your patients with amoxiclav?
With amoxiclav, also with clarithromycin. So from the stomach point of view, the quinolones are the best, sure.
Do you give any probiotics along with amoxiclav if you
always?
Except for quinolones, always. With quinolones, I tend to give antacids.
Yeah, okay. All of them are after food.
Macrolides you can give before meals.
Dr. Sasindran, anything different from what has been mentioned?
So this is with respect to polyps or just plain sinusitis?
No, everything in FES.
Yeah, so again, it would probably depend on the findings. As I said, most of these patients are patients who have already taken medications. Now, if there is an active focus of infection, that is on endoscopy, if I see inflamed mucosa, frank pus, then probably these are patients who would go in for a course of antibiotic. Now, if it is just polyps without signs of active infection, then probably steroids is what I would prefer. And that would be both in form of oral steroids, as well as I generally put these patients on topical steroid washes as well. So that would be subjected to, depending on the kind of pathology that you're looking at. Now, if these patients are not patients who are doing well in spite of repeated medications, obviously we go for scanning. Otherwise, if they're doing well, then they continue the course of medications, because you will actually have to kind of identify what kind of pathology, what subtype of pathology.
Let's say we are talking about chronic polyposis, extensive polyposis. Very quickly from each of the panel, I'd like to know what dose of steroid you give and for how long, and whether you taper it, whether you give it in the morning, afternoon, evening, divided doses, whatever. What is your rationale? Gaurav?
Yeah, so if you're talking about polyposis and if the pathology is eosinophilic driven, then the time duration has to be a minimum of 3 weeks. That's because the lifespan of the eosinophil is 3 weeks. And there's a recent meta-analysis which has come out, which dictates that I mean, it was a comparative study between 1 mg per kg per day for 1 day versus 1 mg per kg per day for 5 days. And they found that 3 parameters are better. That is, operating time is much lower. Intraoperative bleeding is much lower, and the surgeon's comfort during surgery is also much better if it's given for longer duration. So what I do is in my practice, if I'm planning to take up the patient for surgery, chronic polyposis, invariably we are going to operate. And if I'm taking the patient up for surgery, the way I do this is that when the patient comes to me the first time without any steroid, we just take a polyp biopsy. This is to study the tissue parameters. And then we start the patient of 1 week of steroids. And the same steroid gets tapered in the post-operative period and gets continued for the remaining 2 weeks. So this helps us. One is operative field preparation, because you're giving a higher dose before surgery. And post-surgery, this helps the patient to have a much better outcome as well. So the reactive polyposis or reactive edema, which we see in certain cases when we don't give steroids, that's much less. So this is the rationale behind how I intersperse
So you
it.
give it 1 week pre-op and 2 weeks post-op, so that the whole thing covers 3 weeks.
3 weeks.
And what steroid are you using?
I use prednisolone.
1 milligram per kilogram. And you taper it over the last week.
Yes, no, first 1 week, then we taper one step down second week, and again in the third week.
Okay.
1 week each.
Right. Dr. Nishit?
So for me, it'll be 0.5, not 1 mg. And it'll be 2 weeks pre-op, 1 week post-op.
Hetal?
Same, 2 weeks pre-op and 1 week post-operatively.
Dr. Vivek?
It's 0.5. So again, for the initial part of the treatment before imaging, going on to imaging, so usually 3 weeks, that is what we give minimally, and then followed by the 3 weeks of medication we assess. And then 1 week prior to surgery, again, we restart the dose and then continue it for 2 weeks after surgery.
Okay, so I think the panel is basically about 3 weeks and difference of pre and post-op. What about steroid sprays?
All the patients get steroids straight post-op.
Do you give it pre-op or only post-op?
No, when the oral steroids are on, I avoid using the nasal spray. But maybe during the maximum medical line of treatment, yes. But preoperatively, if I'm preparing the patient, is already on oral steroids, then I don't give them spray. I use it for post-operatively after the mucosa is healed a little bit, because after the steroids are done.
You know, we've had this one problem which comes up. I'm sure it comes up with all of you, Nishit. You have patients coming from out of town, and there's only a minimum period that they can stay in Mumbai. And you have to operate them and treat them in that much. So let's say a patient comes to you and he says the maximum time I have is 1 week. In 1 week, I have to finish everything. How do you manage with the steroid then?
So they will already have started the steroid before they come to us.
No, unlikely. They've come to you as a referral without steroid.
No. So they will be told to start the steroid before they come to us, take it for that 10 days at least, then come to us for surgery. And I want to be comfortable with whoever's going to look after them from wherever they come from. So if they don't have somebody who's going to look after them post-op, it's a little more difficult. Then
yeah, this is a real-time issue which comes up when we're. So it's easy to say that. What about antihistamines?
If there is associated allergic symptoms, yes. Otherwise, generally, no.
Why would you not give antihistamines, Gaurav?
So there's 2 reasons, ma'am. So allergy, as we know, there's phase 1 and phase 2. So antihistamines work only in phase 1. So if you're planning to take the patient up for surgery, that means patient is already in phase 2. Even if it is allergy-induced polyposis, the patient is already in phase 2. So you're not doing them a great deal of help by putting them on antihistamines. That's first thing. Second thing is antihistamines, when they block the H1 receptors, they cause actually thickening of the mucus and poor drainage of the sinuses. This is a big problem for them. So already they have a impaired mucociliary clearance. And on top of that, if you thicken that mucus, it makes it all the more challenging for the sinus to clear it out. That leads to stagnation and further infection. This is the reason why I don't prefer to use.
Also the fact that they have blocked noses, and if you give them an antihistamine, it dries out the throat even more and actually can cause upper respiratory tract infection. So the panel is
unanimous on the fact that you would not use antihistamines.
Absolutely.
Yeah, absolutely.
Use mucolytics.
Yes.
Yeah, you'd use in fact, the opposite. What about leukotriene inhibitors? When do you use them? Dr. Patel? Dr. Hetal?
I don't use that much.
No. What about you, Nishit?
So if you have patients who are not eosinophilic, who are not steroid responders, then you would go to leukotrienes. Unfortunately, we have not had that great a response either with leukotrienes, but we have had patients in the recent past with recurrent surgeries still not doing well despite steroids, who are now doing well with biologics.
Dr. Vivek?
Generally, patients who have hyperreactive airways, so basically asthmatic, in those subset of patients, yes, we do try it. Otherwise, not as an.
Yeah, so that's what I do also. If they have lower respiratory tract symptoms, that's when I add a leukotriene inhibitor. Something on my mind. About imaging, I think Nishit really covered everything, but all the same, let's just go over it very briefly. When do you decide to image? When are there patients where you say you will give the maximum medical therapy and then image? That is what most of us would do. And when is it that you decide ki I'm not going to wait for maximum medical therapy and I'm going to image the patient first? Dr. Patel?
I would immediately scan, ask for imaging if I'm suspecting any complications. Otherwise, clinically, when you know, and a lot of patients come to us with scans already done. But if it is a fresh patient who has come, and if initially I will start with the medical line of treatment and then do the imaging.
So how long after you started medical line of therapy will you do the imaging?
At least a week. So that whatever is reversible can be taken care of. And then I would do the scans.
Nishit?
Yeah, I think I always want to see anatomy more than I want to see pathology.
So you'd prefer to wait, do the maximum medical therapy. What about tumors? What would you do in tumors?
So tumors is different.
Yeah, so that's
tumors, complications, you don't want to wait. Like today we did a patient with big nasal mass who had been told medical treatment for 3 months. And we look at the scan, the sinuses are clear. So it was obviously not a polyp. So in that situation, you go and get an MR tomorrow and I want to operate day after.
Yeah. So basically, this rule would not apply for lesions other than sinusitis and polyposis. Right. In any lesion other than sinus and polyposis, you would first do the scans so that you have an idea of what you're dealing with. You may repeat the scan if you want after medical therapy, if you can wait.
Yes. In other words, what will not respond to medical treatment, you don't wait.
Yes, absolutely.
Ma'am, endoscopic findings. So if we, or from history, if you get a very clear-cut view of fungal sinusitis kind of history, patient blowing out cheesy material, or so that is one situation where I would consider imaging earlier. Again, if you have clear evidence, something like allergic fungal sinusitis, where you have thick mucin on endoscopy. Now, again, if there are orbital symptoms, anything with polyps, with orbital
so anything which has gone beyond the sinus, believe has gone beyond the sinus.
And then again, if you see something that is kind of vascular in the sense polyp, but not the classical polyp, anything suspicious, I would consider imaging.
Gaurav?
There's two situations, ma'am. One is if the etiology is fungal, whether it is allergic or invasive. There is no role for medical management before surgery in both these situations, allergic or invasive. Second is, if there is the symptoms are, not correlating with the signs, like some patients who complain of extreme amount of pain, and you see that the sinus, when you do an endoscopy, is not correlating. In such situations, I think it's ideal to scan to figure out what's happening, because we had there's been a recent flurry of patients who've come in with central skull base osteomyelitis. I'm sure you also must have had your fair share of these patients where you don't see a lot happening in the sinuses, but the disease is submucosal in these cases. So it makes sense to do a scan and figure out what's happening.
Yeah, so sometimes when we all must be getting patients with scans, and the first question that I ask the patient is, was this done when you had a cold?
and you were not feeling well, or was the scan done when you were feeling absolutely well? And when I ask for a scan, I always tell the patient that do it when you feel you're at the best. At the best of your condition, that is when you do the scan, because we're looking for irreversible disease in sinusitis and polyposis. Nishit was very clear about that he would want to have the DICOM images. Would you also need the plates?
Yeah.
Why do you need the plates if you already have the DICOM?
On the films in front of me.
Correct. So the point I want to make here is that you study the scans on DICOM images, but you need to have plates because you can't navigate the DICOM images while you're operating. And it is very frustrating. Thoda aage jao, thoda piche jao. So you need to have plates.
Unless you're using navigation.
Unless you're using navigation. We'll come to that in a little while. Nishit, will you please keep Kshitij, will you please keep a timer and let me know about 10 minutes before we need to close down? I think we will go over these very quickly because we've already had Nishit talk about when he would do an MRI, when he do a contrast enhanced CT scan, and when do not wait, that we've already discussed. Any specific things that the panel would like to say about contrast in CT scans and contrast in MRI, which was besides the lecture that Nishit took? Any specific points in your mind?
Any patient with a history of epistaxis or suspecting vascular lesion, then you ask for contrast. And sometime when you want to know he very nicely said about the peripheral enhancement and all in the cases where there is an inflammation also, it would help in case of mucocele, pyocele also.
Right, to differentiate the two.
No, I think the earlier practice was to go or request for more of contrast enhanced CTs. But I think Sir clearly specified that in the talk that we should be focusing more. So rather than doing a contrast enhanced CT, get a plain CT with a contrast enhanced MRI. So that gives you much more information regarding if it's a mass lesion, that definitely gives you much more information because many times that could be even diagnostic.
Yeah. And I think one very important point is that if you have any lesion around the carotids, then in that case, the problem is with the contrast enhanced CT scan, the carotid looks white and the tumor also looks white. So it's very difficult to make out the interplay between the carotid and the tumor. Whereas if you do a contrast enhanced MRI, then in that contrast and the tumor is white, it brightens up, but the carotid will still appear dark. And if you have, you can sometimes see a ring around the carotid, which is the vasa vasorum. And if you see that ring intact, it means that possibly the tumor is just abutting the carotid. But if you see an interruption in that ring, then you can say that a possibility of the tumor actually adhering to the wall of the carotid. So therefore, I think MR with contrast specifically for visualizing the carotid's interplay with the tumor is non-negotiable. This is just to put up that this is, a patient who came to me with this scan, and then after 2 weeks of therapy, this was what I saw. So obviously the timing of the scan, and you can avoid surgery where it's not needed. Also, when the CT scan shows a pathology, the eye is drawn to the pathology. And therefore you first see the pathology and then you start, you may miss something important because you're so focused on the pathology, which Dr. Nishit said very clearly. This is a patient with an angiofibroma, and you can see that actually it was a revision case, and you can see this prolapse of fat over here. And this is the endoscopic view. That's the tumor. And this was the prolapse of fat, the small prolapse of fat. And in the reporting, even the radiologist had missed that. So while what Nishit said was very true, that first look at the anatomy and then look at the pathology so that you don't miss very key important things on anatomy. So as far as allergy testing is concerned, when do you do it and what are the tests you ask for? Gaurav?
So, ma'am, if the patient has, classic features, that is running nose, itching, sneezing, and a blocked nose. So,
yeah, so either he's a runner or he's a blocker.
So that is RIBS. That is what I call running, itching, blocked nose, and sneezing. And on endoscopy, so the telltale sign on endoscopy for a patient who's got allergic etiology would be that you will see middle turbinate edema. Now, there are multiple grades of this where you have focal, you have polypoid, and extensive, diffuse, and you have polypoid. These are the 3 grades. If you find that there is edema of the middle turbinate in any of these three grades, so that it is more specific finding where you have to do allergic testing. That means this is of eosinophilic etiology. So that so the first test that we do is a skin prick test. It's important to tell the patient not to take any antihistamines at least 1 week before, because if they do, then the test is going to be negative. So the second test which we do is a total IgE in these patients. We don't do a specific immunoglobulin level until later if it's really required. But these are the two tests that we usually prescribe as screeners.
Vivek?
We don't, I mean, IgE, yes, we do look for IgE levels. Apart from that, the allergen testing per se, it's just reserved for refractory cases, not as a routine. It's not our primary modality of investigation. So you have patients who are put on steroids, sprays, antihistamines, but the minute you stop it or you stop the antihistamines, they have recurrence of symptoms. And again, patients with lower airway issues. Now, these are the subset of patients whom we would probably target more for further testing.
Nishit?
Yeah, I agree with Vivek. And the only other thing which I'm not doing yet, but I think I should be doing is a PFT for these patients.
Hetal?
So definitely those who have got associated lower respiratory tract infection, then those patients we could do the testing.
Also, as you mentioned, the middle turbinate, I just also like to say that there's one more sign you get, and that's the morulated inferior turbinate. So if you look at the posterior end of the inferior turbinate, it will show crenellations. It will look, like polypoidal kind of appearance. So obviously, and then, you have to also see that if it's a blocker, how much of it is due to those inferior turbinates besides the polyps, and the deviated nasal septum if it's present. A very quick yes or no from each of you. How many of you routinely use slit, submucosal, sublingual immunotherapy? Routinely? Or in what percentage of your patients? Let's say you have 10 patients. How many of them will actually go in for slit?
I think about 2 or 3.
I don't deal with that because it's sent to our respiratory department. So they are the ones who
Yeah, but of your patients, 10, how many would you refer?
I can't get it.
No, you don't. Okay.
Out of 10, maybe 1 or 2.
Same 1 or 2.
1 or 2. Okay. Let's go to diagnostic nasal endoscopy now. There are 2 questions I have. One is, would you do a diagnostic endoscopy in the outpatient department or in the operation theater? Now, I'm not talking about that first initial thing which you do to show the patient what is there. I'm saying that you're actually, let's say there's a patient with epistaxis and minimal epistaxis, not profuse, just he says blood-stained nasal secretions. Would you, and you want to really check what it is, will you do the endoscopy in the outpatient department in a procedure room, or would you prefer to do it in the operation theater? Hetal?
It is very variable because if you're in a private setup, operation theater is going to charge you, and if you have a nice reclining bed in the OPD, you can as well do it in the OPD.
So how do you decongest the nose in the OPD?
Put 4% lidocaine patty, wait for it. Do the same thing what you do it in the OT. Or a lot of people, even the reclining chair, now what we have in a workstation also works very good.
So as a routine, I don't do diagnostic endoscopies, especially if you have polyposis or obvious diagnosis patients. I would always do it if I have a revision patient and if I'm unsure of diagnosis. So I'm not sure in polyp, papilloma, or like you said, if there's some sanguineous discharge, then yes. But as a routine CRS polyps, no.
Do you, Vivek?
Ma'am, you said mild bleeding epistaxis case. Yes, routinely we'll try to have a look in the OPD itself. But if it's a case which is packed, where they mentioned that there was severe bleeding packed, in those kind of cases, we would prefer taking the patient to the OT and then removing it.
My answer is a little different, ma'am. So we have an endoscopy room in our hospital. And so I scope every patient that walks through my. So we do the scoping in the endoscopy room with a pediatric 2.6 mm scope. And ideally, I scope the patient without any decongestion or, nasal spray. The reason being that I would like to see the nose in its, nascent stage first. without me doing anything, because when you spray them, they start secreting a lot of mucus, and you might overstage or understage the problem. And if you decongest it, you will not know the true extent of his blockage as well. If you really are not able to see anything, and now that you know that this is the extent of the issue, then you can actually pack them and then take them up for repeat endoscopy if really required. That is what I would.
Yeah, that's an excellent point, that you want to see it in a nascent stage. Ideally, I would suggest that even when you're doing a patient with a blocked nose, you're operating, we're talking about sinusitis and polyposis. Before you pack for decongestion, look at the nose and see how far behind can you see into the nose. So suppose a patient has a deviated septum or a spur, but preoperatively, he says left nostril, there's not much. And if you preoperatively can see up to the nasopharynx, then you know that spur is really not the reason for his blocking. You will look for something else. So before you start decongesting and putting patties, ideally you should look at the nose in its nascent stage to see what exactly is the issue. And then of course you will decongest, because once you decongest, it's very difficult to make out that what exactly was the problem. Would you like to add something, Nishit?
Yeah, that in a private setup, we tend not to pack at all. If we have to do a diagnostic, it is just decongestion drops, apart from what Gaurav said. And then we use a 4% spray.
Yeah,
I think it's also an important thing, like generally with topical, that is with xylometazoline, that is usually the second part, the second half. So initially with just plain xylocaine, we just have a look. Then instill drops pack. And this is one of the ways by which you can assess if there is a role for turbinate hypertrophy causing obstruction. So that is where you take a call on if something has to be done regarding the turbinate. So if it doesn't reduce, so that is again something that helps in decision making.
I just want to clarify that we don't charge our patients extra for doing that endoscopy. It's a part of the consult itself. So that,
Yeah, we leave
Not to
charges
mention
out of
that you
this because we want to disillusion these young people sitting here.
He's not mentioning that he has 10
One way or
pediatric
the other.
scopes.
10 pediatric scopes.
Yeah, we have to, because at least the kind of crowd that I get in my hospital is all educated IT people. So I have to have some which go off for sterilization, and every month or 2 months, our nurses break one scope. So
we'll stay off that topic. And as you can see, the loudest laughter you're getting is from my residents.
That's partly intentional.
No. Now it is so bad that I have to rub them at the whole area now. So I'm planning to do that too.
Okay, getting back to the topic, when I have history of epistaxis, I will ask very clearly that is it just blood stain secretions when you blow your nose hard? Or is it drops of blood which come without anything? Because if it is drops of blood without anything, I will be very, very careful in my endoscopy, because I don't want to trigger bleeding in the OPD, which will then cost me a lot of patients sitting outside, besides the patient who... And the other thing is, please remember that if you're using xylocaine sprays, you must have basic emergency care with you. We've had a patient who on a xylocaine spray developed anaphylaxis. So I've seen that. So that's why I would suggest that to one. And if you're going to do a diagnosis, suppose let's say that you think it's a meningoencephalocele, or let's not take something like that. Let's say that you're not happy with your diagnostic nasal endoscopy. Would you do that diagnostic nasal endoscopy before or after you've got the CT images?
Before.
No, it depends. If the CT gives me enough information, I may not need the
diagnostic endoscope. So you would always do a CT scan before?
No, not always. It depends on the pathology. It depends on sometimes your gut.
Yeah, your gut feeling. Okay, so can you just describe that a little more, gut feeling? With an example.
Not with bacteria.
No, if the patient walks in with a CT scan, if that is...
No, that of course is besides the point. Let's say a patient walks in fresh. And you
always have a...
Give me one example where, Nishit, give me one example where you do the CT scan before, and one example where you do a diagnostic endoscopy before. While you think it over.
If you have like a nasal block with a bad deviated septum, then I don't want to push my endoscope in where I feel it might cause pain or potential bleeding. Then I'll do the scan, see if I get enough information, and only then do the thing. But if I have something which I will not know on scan, like a revision surgery, is it soft tissue, is Sinike, is it pathology, then I must put my scope in, irrespective of when I do the scan. Sometimes the scan will help me to look for areas which I may not look at with the diagnostic pre-CT. And sometimes it's better to do that so that I know I need a CT or not.
Yeah, brilliant. That's he's explaining gut feeling here. That's basically when you have a hunch or you have a gut feeling, it's actually the cumulative experience that you have over the years, which is giving you a nudge. You know, when you get that hunch, it's usually experience which is talking. Hital?
And also, when am I suspecting that it's a vascular mass or something, I will not want to put endoscope unless I have my scans and unless.
So you know what you're putting your foot into. Okay. Embolization, preoperative embolization. I have 3 questions. One is, what cases will you do it in? How long after the embolization will you operate? And about the balloon occlusion test. So let's start with Nishit.
I don't know. I refer my patients to you. So, no, to be honest, I don't do much of GNA surgery, and most other surgeries don't require embolization. For whatever reason, if there's a vascular problem, then it should be within that 24-48 hours.
Okay. Hetan?
I usually prefer embolization 48 hours prior to the surgery because the first 24 hours there's too much venous return and I would not want to operate onto that. If I'm doing a case where there is a revision case or where there is a big ICA supply, then I will definitely want to do a balloon occlusion test and see whether there are enough collaterals or not.
Gaurav?
There's been only one case where I had to embolize so far. And in fact, that is the only case which I had to stage also. So this was a glomerulonephrocytoma. So extremely vascular tumor. I've never seen such kind of vascularity in any tumor in my life. The problem was in the stage 1, we were only able to remove the maxillary component, and the guy had lost so much blood that, you know, the parameters were, you know, sort of decompensating. So in such situation, I decided to do it, embolize it, transfuse, and then take him up again after 2 weeks. But nowadays, with the advent of, you know, with coblation in place here, the requirement for embolization is drastically dropped. And if you can actually do a good study of a MR angiogram, you can actually plan your surgery much better. Where I think, yeah, you have the pull push technique. You can also create accessory portals and sort of clip the blood supply in the beginning of the surgery itself and then proceed with the surgery.
Yeah, I remember we've had this discussion about modified endoscopic Denkers as well as with the 4-port or push-pull technique.
Absolutely, ma'am.
So I think, what are you doing now?
Whatever I've learned from you, that is, we're doing multiportal surgery these days. And I mean, no tumor is, inaccessible is what I'm finding and I'm learning. The simple funda is if the tumor can reach there, I think so can you with the endoscopic approach. It's not that it's so difficult. With regards to the balloon occlusion test, if there is a tumor which is either, making a dent into the carotid in either one segment or more than one segment, more so in more than one segment, then it makes sense to do a balloon occlusion test. Like you said, if the ring is missing, part of the ring is missing or it's incomplete, then it would be a good idea to do a balloon occlusion test, because when you're peeling the tumor off, you might strip the, one of the layers of the carotid. And you should know, and you should have a preoperative counseling session with the patient that this is what we might need to do, because the problem is not going to be that whether or not you can stop the carotid bleed. The problem is going to be the pseudoaneurysm that's going to follow. And if you don't have a proper plan in place, then you're going to have you might discharge the patient. He's going to sneeze or cough on the street tomorrow. And before he even knows it, he'll be dead. So that's the reason.
Right. Vivek?
Routine embolization, no. Primarily because one, we don't have interventional radiologist at my center. But then few cases that we operate elsewhere where there are facilities, they do recommend embolization, but generally I don't ask for. Now, when would I consider embolization? Yes, as on an angiogram, if I'm not able to, if I feel that I wouldn't be able to clip the vessel, especially for a JNA. If it's posteriorly, if the vessel is posteriorly placed with a far lateral extending tumor, then probably I may consider it. But then having said that, many a times we get away without embolization. And frankly speaking, I haven't found much of a difference to say for the amount of money that the patient has to shell out and the kind of blood loss, what we are talking about, I think it's almost the same. And regarding BOT, yes, certain specific indications. One is radiologically, it is not just indenting where you think it is encircling, or if there is significant narrowing of the intraluminal narrowing, revision cases. Now, these are specific situations where I would consider doing a BOT.
And post-radiation also.
Yeah.
Post-radiation. So basically one rule of the thumb is that if you think he needs a balloon occlusion test, then you definitely cannot operate in a center which doesn't have interventional radiology.
Absolutely.
So when we do a balloon occlusion test, especially when we find that that we're going to be working around the carotid, you know, it's not just abutting it, but it's encasing. In that case, we do a balloon occlusion test, and when we start dissecting in that area is when we tell the interventional radiologist that we've reached this area and over the next half an hour or so, 1 hour, we may need you as standby. So always, so, you know, people do say that I don't need an interventional radiologist because I don't do embolization. But if you're going to operate in that area, in the cavernous area where the carotid is, then you need to have an interventional radiologist to whom you can wheel your patient if there's a carotid.
So I think that that's a very valid point, because although I said that I don't have an interventional radiologist at my center, in the neighboring, just adjacent hospital, we have an interventional setup.
Yeah.
So that
So
is
you have access. Yeah, you have access to
that. Absolutely.
intervention.
And it's also important to involve these guys in the preoperative planning itself. So we have an MDT for every skull base case, then the whole MDT consensus gets printed out and the plan gets printed out. And the patient is also there in the MDT. So it's important that we update them before the surgery, not after we've created.
Yes, absolutely. So we do, like you said, preoperatively, we inform them of the date when we are going to take this patient up. And also for the younger people, make a beautiful, actually develop a wonderful relationship with your radiologist. Keep talking back and forth, have constant conversations that will help both of you. Okay, now the important thing about consent. So what are the important parameters that what are the boxes that you tick when you're taking a consent for a patient, let's say of, we'll come to the disease later, but general consent, if you're taking for a paranasal sinus, we're sticking to paranasal sinus here, paranasal sinus disease, how would you take the consent? What are the essential things that you will incorporate in your consent, Hetal?
I try and use the association's consent form. You're
talking about the Rhinology.
Yeah, yeah. And I also tell them that we are going to work very close to the orbit and the cranial cavity. So there is possibility of having complications. So I go in much detail when there are well-read patient and who keeps asking about the all the possible complications, because there are certain group of patients who will walk in and tell me, you tell me, doctor, what are the complications in this? Then I will tell them in detail all of it. Otherwise, I would tell them that there are possibility of bleeding and the basic complications. I would tell them and will not go too much in details.
Okay, I'll just put up a set of questions that I have. So let's take these two pictures. Okay, they're both allergic fungal rhinosinusitis. Nishit, would your consent for both of these be similar or would they be different?
The consent will be similar. The explanation will be different. So the way we talk to the patient will be different. So with the second case, I'm going to increase my risk of having a complication from say 1% to 2%.
Do you give percentage to your patient?
Yeah, because when first of all, I'm not going to be ambiguous about explaining the complications. I will tell them very clearly anesthesia, bleeding, orbit, CSF.
In
These are
this
your-
particular patient or even in the first one?
Any patient of CRS and FES. They're told very clearly these are the complications. And it is offset. Because I tell them in my hands, your risk of having with a regular CRS patient, your risk of having a complication is 1% or less. What happens if you don't have surgery? The risk of having a complication because of sinusitis is also 1% or less. That you can get a meningitis or an orbital abscess, etc. So that's the reason I have to give the percent. That is not very different if you have the surgery with me or if you don't have surgery. And so let's get you a better quality of life.
Vivek?
Ma'am, probably 15 years back when I started practice, I would list out all these complications. I mean, obviously your beginning days, your learning curve, we would emphasize on each of these complications. But then I think now, yes, we do emphasize, but then the list of complications comes way down. Now, coming to different scenarios, now you probably talk about bleeding in all the cases, orbital injury, CSF, yes. Now, carotid injuries, not in routine cases. There are certain scenarios. So generally, you tell the patient that these are there, these are possible, but whatever happens, we generally would be able to manage it. So that is what I just tell them, because if you start listing out complications, then
Patient might run away.
that is one. And now there are patients whom you would, as ma'am said, patients who actually Google, do research and come talk about these kind of complications. I mean, you would probably sit with them, spend more time explaining about the percentages and things. But otherwise, generally, it is something with experience where you learn how to counsel. Right?
So you will list the possible complications and then the likely possible out of those likely ones, out of the possible, and then give a percentage of how likely it is in your hands. That would be approximately how you would do it, Nishit. Gaurav?
So you know that we had this app which I showed you, and we consent through that. So this was done with a medical legal team. So every consent is supposed to have 6 parts. The first is your introduction, explaining what is the problem that you have and briefly about what is the global standard. Second part is what are your alternatives to this treatment. Third is what are the complications which are possible. It could be surgery related and non-surgical, like anesthesia related, like Sir said. And fourth part is what are the patient's financial obligations, if there is a complication, and even otherwise, in terms of even insurance, if insurance doesn't cover. And sixth part is whether we have any additional information. Like in this case, you might want to say antiarrhythmoid is in a mesentery. So I have explained this. And in that case, the dura is, exposed. And the sixth part is what happens when there is a complication. What would be the surgeon's obligation towards you? Like I might operate for free or whatever it is that you have to mention. So these are the things that we have to enlist out. It's not what you say to the patient which matters. It's what you've written that will ultimately matter, because you will have to look at this patient from a medical legal point of view.
Yeah, we're going to come to that if we get time. So disease specific your consent should be disease specific. Anyone who does a video consent?
So I would start by telling the patient, I'm not telling you these complications to scare you, but because it's a medical legal necessity to inform you. And I do this with every patient. So it's not, you are not special or there's no extra risk in your case. And I think if you all want to be better surgeons, you all must have this comfort. When you operate, if you've not taken a consent, there is no way you're going to clear the skull base properly. There's no way you're going to go up to the orbit properly. And you're going to just sleep pre-op also much happier. Intra-op, you're going to be a lot happier than if you don't take a clear, informed consent. And an informed consent means you cannot just beat around the bush that there may be this, maybe that. Informed consent means you clearly explain to them the major complications. You don't have to go into K formation or infection or minor things. But the major complications must be clear, tuck, give them the consent form at the end of it, take your time, read it, give it to me the next day.
Yeah, so I think what you said about comfort zone is very important. If you want to push the envelope, if you want to go one step further than your experience, if you have a good consent taken beforehand, you will go in with comfort, because I've already told the patient that this could happen and what I would do if this happens. So the chances that if you've never cleared the skull base before, as he said, you will make that move to clear the skull base if you've already told the patient about it. And we've already discussed this. What is the position of the head of the patient while doing FES surgery? Hetal?
I have supine position with 30-degree head high. I never do the extension.
You never do the extension. Even for the frontal sinus, you don't.
I would rather switch to 70-degree telescope, but I will not change the position.
Gaurav?
15-degree head up, and head extension if I'm finding difficulty in the frontal sinus. Sometimes even with a 70, if I'm finding it tough, then I would. Like I had to do that recently for a posterior table CSF leak repair. Yes.
I will always have some extension. I just find my instruments will hit the chest otherwise. I'm just very comfortable with a little extension.
It's head and elevation. That's
okay. So the reason why we are discussing this, again, addressing the large number of young people here, that when you extend the head, you open up the skull base to the trajectory of your instruments. And so the chance of going through the skull base are higher technically if you've extended the head too much. But the problem, therefore, if you keep it semi-flexed, actually the orbitomeatal line has to be perpendicular to the plane of the table. That's how much it should be flexed. Then you're working parallel to the skull base. But the thing is, when you work in that trajectory, getting your instruments into the frontal recess can be a little more of a challenge. You may have to shift to an angle scope much earlier. Whereas if you extend the head, so for the frontal sinus, I do extend the head, and then the trajectory of the instruments is easier to manage. But as soon as the frontal sinus has been opened and well cleared, then I will flex the head again. But definitely the rest of the sinus is always with a semi-flexed head. Okay, this I want very quick, just, one-line answers from all of you. What solution do you use? Patties? Do you use Merocel? What do you use for decongesting the nose? Second, what is the concentration of solution that you use? Hetal?
4 ampoules of adrenaline and 30 ml of 4 ampoules of adrenaline and 30 ml of 4% lignocaine. I used that solution, and I used Merocel squeeze patties.
Okay.
More patties than Merocel, rarely Merocel.
And solution? Same. Vivek?
It depends on the nasal cavity. Now, very narrow nasal cavities, I would probably use Merocel. Otherwise, I generally use gauze.
Gauze.
Yeah.
Strips of gauze.
Strips of gauze.
And the solution that you use?
If the patient does not have any cardiac comorbidities, if it is not a pediatric patient.
No, we are talking about a routine patient.
Yeah. So otherwise, healthy patients, I use pure adrenaline for packing.
Pure adrenaline. Okay.
No infiltration, only packing.
Yeah. No. And you, Gaurav?
So adult patients, 1:10 adrenaline to normal saline with Merocel. Pediatric patients,
which means 1 ampule in 10 cc.
Yeah, and pediatric patients 1:20 with Merocel.
Okay. Do you infiltrate?
Always.
What do you infiltrate?
2% of lignocaine with.
Where do you infiltrate?
Solution. I give one infiltration for surely along the uncinate process. And if I'm having a lot of posterior work, then I do sphenopalatine block also at the posterior end of the middle turbinate.
Do you do a greater palatine block?
No, I do it from the transnasally.
Transnasal.
For FES, never.
No.
Only for the concha or for septal correction, infiltration.
Okay.
Otherwise, no.
My septal infiltration is with normal saline. That's for hydrodissection.
Hydrodissection.
Yeah,
Okay.
not with.
So we use 4 ampoules in 30 cc, and I don't infiltrate. And we do 2 sets of packing. So first set is just general decongestion, and the second into the sphenoethmoidal recess, into the middle meatus, so that it's easier to go in if you're, and under local, of course, you would do it twice so that the pain is less. Okay, now let's say you're operating, and let's say this time you're operating on, say, an inverted papilloma. Then how do you manage hemostasis? Gaurav?
So there's the first thing is the patient position itself. So if you've got a 15-degree head up, and this number is quite important because they also did a study which found that if you do it any more than 15 degree, then there's actually compensatory tachycardia which happens. So up to 15 degrees is great. So you can do that. And second thing is you need to tell your anesthetist that you need to have some amount of hypotensive anesthesia of the heart rate and the blood pressure. Heart rate is more important than blood pressure.
What is that product?
So this is a product in the sense like
Means you multiply the
mean blood pressure. So mean arterial pressure. That is and we need to have it 30% lower than what the patient's resting pressure is. So we don't have a fixed number like 90/60 or 70 heart rate. That doesn't work because you might be pushing the patient into cerebral hypoperfusion if we try to do something of that sort. So whatever is the patient's resting blood pressure measured thrice, you take an average and 30% less than that will be your hypotensive anesthesia. And the third thing is, like you said, we can always use either gauze soaked in adrenaline or Merocel soaked in adrenaline intraoperatively. So that will help with the mucosal oozing.
What do you use?
For tumors, I prefer to use gauze because we do a bit of stripping of mucosa to ensure complete tumor resection. But for sinus surgery, I use Merocel.
Vivek?
Ma'am, hemostasis, yes. So when it comes to a bloodless field, basically it depends on the pathology, your pre-op preparation, the anesthesia. So obviously you have to have a good rapport with the anesthetist. Now intra-op, yes, adequate decongestion. Apart from that, copious irrigation, warm irrigations we use. And then packing with adrenaline, waiting for it to stop. Yeah, so use generally if there is profuse bleeding, it wouldn't stop with Merocel. So that is where I prefer gauze packing. Yeah. So that is something that helps us apply more pressure. But then again, the issue with gauze is in narrow nasal cavities, it can traumatize the surrounding collateral mucosa. So that is something that we need to be careful about.
So especially something like rhinosporidiosis, you'd be more careful about gauze. Yes. Yes, Nishit?
So apart from what has been said, you can switch sides. So you give it time for hemostasis.
So if you're operating in the right nasal cavity, you move to the left and just pack the right nasal cavity.
If sometimes you feel this generalized, but if you really do a proper suction packing, you find it just one point which is bleeding. So then you can cauterize it. And third thing, which I find often useful, is to open spaces. So for example, if you're doing an intact bulla for a frontal sinus, that blood tends to trickle down the anterior face into your scope. So if you open the bulla, then the blood tends to run backward. And then you have an easier field to work. So you open spaces. It's very rare that you, maybe in tumor surgery, that you actually need to put a catheter in to suck blood. But if it comes to that in FES, you should have stopped by then already.
Yes, Hetal?
Usually I follow the same thing.
And right. I think sometimes you have these kind of chronic cases with a lot of osteitis. That invariably irrespective of packing, preparation, those tend to bleed. So there sometimes I use a polishing bird to kind of polish it and smoothen it and
basically
the bleeding.
Without irrigation.
In fact, some of the pathology or if there is a lot of bleeding occurring, if you clear the pathology quicker, then you may just feel that the field is already taken care of.
Yeah, so if you have a vascular tumor, whatever you delineate the areas which are safe, and go gung-ho very fast with removing the tumor in these safe areas. And then you've got the bulk of the tumor out, then the bleeding is easier to control. Otherwise, the bleeding is coming out of the nose simply because there's no place for it to go behind. We do all of this. We also have, especially when you have an arterial bleed and you can't locate that artery, or for example, your cautery stops working, we have these betadine laddus that we make. So basically you take a gauze, roller gauze of 6 inches or so, you apply a lot of betadine ointment to it, then you strip that betadine ointment so there's not excess of it. You don't want paraffin, completely flooding your, and going into vascular spaces. So you strip the extra betadine and you roll it up into a ball. And with the Blakesley, you can put it exactly where you think the bleeding is coming from predominantly. We've used this in carotid blowouts also, where we plug it exactly. It works very fast than the Swiss roll technique, because by the time you try to get that pack in, everything is flowing out. So I found that it works very well like that. And it really, because of that stickiness to it, it really controls bleeding very well. So we are all fond of laddus at my center. Okay, when do you use neuronavigation? Okay, that balloon cyanoplasty will let go of. But when do you use neuronavigation? You don't use it even for intracranial tumors?
No, ma'am. I have a neurosurgeon with me for those cases. I think the one case where I used was an orbital apex tumor, which was only about 7 millimeters. So for me, it was important to know the exact coordinates of that tumor because I don't have a lot of space to play with. Otherwise, I feel the larger the tumor, the easier is the surgery for you. So when we're talking about intracranial tumors, we would have obviously done a MR angiogram. So you know which vessel is inside the tumor, and we use a CUSA there. And there is something called as tumor brain interface, which I have learned to identify very well thanks to my neurosurgeon. So you know how much tumor has to be resected. If at all neuronavigation, there is one more case where post radiation, a patient comes to you after radiation, then to assess the completeness of your surgery, it's a very good tool to have.
Vivek?
Not a routine, but for situations where you have gross anatomical distortion, bony landmarks expansion, remodeling, in those kind of situations, probably I would consider. And revision cases sometimes, but generally not.
Nishit?
In skull base, all revision cases, even if it looks very simple on scan. When you have non-pneumatized or not well pneumatized sphenoid sinuses and you want to go to SELA, if you have multi-compartmental pathology, so you're not sure whether you've entered the right compartment or not. For sinus disease, not very often. I would say maybe if at all for revision cases when you've had things chopped off and a lot of neosteogenesis, you think it might make a difference.
Yeah. So we use it when we have Lefort fractures, where the anatomy is completely distorted and there's callus formation. Hetal?
Some of the bony tumors maybe where you don't know the limits. So that is one place I like to use it.
Yeah, it's a good point.
Yeah, I think US has gone completely the other way, where they want to have a neuronavigation for every case, and that it's medico-legally an issue.
Medico-legally.
Medico-legally.
If you think you can make it safer, then why aren't you using it?
I don't know whether it really makes it that much safer as it just takes a lot more time for the surgery.
Not only that, not say if you don't know how to
read,
use it, then if you don't have a good internal navigation, there's no point of having an external navigation.
So I think it works both ways. There are some surgeons who use navigation or very fast, but they're looking at navigation and so are looking at mucosa. And so though the surgery is quicker, they're causing more mucosal trauma because they're just following the probe without looking at what they're doing. But sometimes for beginners, it's a good learning tool because it helps you avoid that same mucosal trauma if you are patient and careful about how you use it.
Yeah,
I think it is definitely a good tool during your initial learning stages. Probably it helps you gain more confidence, especially like working the frontal, identifying the skull base. But those things, it's good. But then totally relying on neuronavigation, I think it is not the right
it's
thing.
It's not a replacement for knowing
you can't just be dependent on the neuronavigation.
Yeah, but one thing I'd like to state here is that to be able to read the neuronavigation, triplanar neuronavigation, you must have a very strong internal navigation, as Gaurav said, and you must have a very strong grasp over reading scans. Because if you don't have that and you're reading the navigation, you may get lost reading that navigation because you just don't have the background knowledge or the context in which you're reading that.
If I can add a situation with navigation, halfway through it went off. So you have to understand that your pointer is not pointing at that spot where it's supposed to.
Yeah, and make sure that you what is the error between the actual probe and pointing at the thing. So one of the places, and don't use the tip of the nose because it is collapsible. So never use the tip of the nose for referencing. Use something like the anterior nasal spline or use the anterior end of the middle turbinate. So you need a structure which won't move. So very quickly, I'm told that we should stop now. Let's just answer this question for me. How do you prevent pain while removing packs? First of all, what pack do you use? And how do you prevent pain while removing packs if you put packs?
I don't pack. No.
You don't pack in the middle meatus?
No, I don't pack. There's only been twice that I was forced to pack. One patient was hypertensive, had a bleed post-surgery. And the other one was a extremely vascular tumor that I spoke about. There's only these two situations where
What about that serosanguinous discharge which keeps coming out of the patient's nose?
I mean, that's kind of expected. And I tell them that it's better out than in. So if it remains inside, it's prone to get infected any which way. So it's better. The whole point of doing the surgery is to allow your sinuses to drain better.
No, so you tell them to keep dabbing
it out. And in fact, I make them do the wash from the first day itself, only with normal saline, no salt or anything. So just to flush out whatever clots and mucus is there. If you have controlled all your arterial bleeders, then I think you're good.
Okay. Vivek?
No, I generally put a pack in for
what pack do you use?
The Mirocell pack.
Okay.
So overnight packing is the next day morning it's out.
Okay.
So I did experiment a little bit, like Gaurav said, with not packing at all. But I found that in the middle meatus, blood collected and formed clots and became more difficult for me to clean it than if I had packed even for one day. So generally with only sinus surgery, we use 4 centimeter sinus packs, which are easy to put in and take out. And if you've done a septoplasty, then you would have to have nasal packs.
Same. Okay.
You do get inflatable packs for the nose. So if you use those, then you can deflate it and it's very easy to walk out.
Yeah. Do you ever use glove fingers?
Yeah, that's the way to prevent pain.
Yeah, so you would use gloved finger stalls.
We used it, 20 years ago when we were doing skull-based surgery and you were scared that it'll pull the reconstructions. But now, no, we stopped.
It was very favorite of Dr. Ingle.
Also,
before Mirocell came in, we used to put gauze piece on the finger glove and use that only as a pack, and it was so easy to come out. It just walks out.
But you have to make holes in the glove so that the water fills in the Mirocell instead of having it solid.
You can use the cut end of the glove. You suture it. So then you have two things: one thread of the Mirocell and one thread of the glove out to hold. Post-op douching. What solution do you use, and when do you start douching? Hetal?
Immediately after the pack removal, I keep pack for one day only. And on discharge, I tell them to do the nasal douche. Only when the lamina is open, that's the only time I tell them not to do. Or if there's a CSF repair. These are the two patients, no douche. Otherwise, the rest
What solution do you use?
We usually tell them to make the solution or nasal wash. So, 2 glasses of water, 2 spoons of eating salt and 1 spoon of eating soda. And if they want to buy the ready-made one, then those ready-made nasal washes.
Normal saline.
The ready-made nasal washes. Now, so we usually start the very next day itself. Yeah.
I just use normal saline.
Okay. We've already discussed steroids. What is the, just 2 slides now. How often do you follow up your patient of sinusitis and polyposis? Gaurav?
First scopy will be 1 week after to just clean up to debride the cavity and allow them
You always do a scopy 1 week after? Yes.
1 week after I do. And the
Anyone who doesn't agree with that in the panel?
So we would do a headlight cleaning 2 days afterwards, just to clean the nose and start washing. Because sometimes there are clots in the posterior part of the nose and it's not easy for them to circulate the water. But the first endoscopy for me would be about 5 or 6 days. So yeah, close to
So 1 week. Anyone else has a different view?
I have been doing now less and less of post-operative endoscopy. After I've started doing every surgery, I do a septal stitch with the turbinate. So the area is so wide open that you really can put 4 patty and just remove that and it's all clean following the nasal.
I think that's a trend now. Most people prefer not to rely on
my early days. I used to do a lot of endoscopy and I realized maybe that also causes some aberrations.
I think one of the problem if we don't scope is sometimes, there could be the beginning of a synecdoche. Now, if you could kind of pick it up, just sort it out then and there, because if you're going to scope the patient 2 weeks later, by the time already addition would have set in.
Right. And follow-up imaging of a tumor?
3 months usually.
What tumor?
Any tumor, skull-base tumor, paranasal sinus
If you
tumor.
are doing skull base like a pituitary, then maybe 3 months. Paranasal depends on pathology. Malignancy, benign. It's different for every patient.
If it's a malignancy, then at the end of 4 or 6 weeks, when my radiation oncologist wants to plan his therapy, he's going to do a PET scan anyway. So that is when I get to see if there is anything left out or.
Usually, if we have a tumor, we would do a post-op scan before discharging the patient once to be sure whether we've cleared everything or not.
Like for JNS,
Yeah.
we do.
Yeah.
But not for pituitaries, no.
Yeah, pituitary wouldn't do it because.
Yeah, but skull-based cases, most of the times they at least get a, if it's a significant intracranial extension, most of the neurosurgeons would get a CT scan the next day. Most of them usually
So
get.
we would not do an MRI. We'd do a CT scan. So that's one thing I wanted to make is that the point is that post-op imaging would be a CT scan and not an MRI. In fact, if you do an MRI immediate post-op, it looks like the pathology is all still there.
Absolutely.
Nothing has been operated.
Also, it takes too much time. You don't want to inconvenience.
Yeah. Okay. This brings us to the last slide. Okay. Just one thing on this. Any thoughts on these 3 things specifically?
So immunotherapy and biologic agents are definitely gonna,
change things.
Yeah, they're gonna change the scenario. But the thing is, biologic agents, there's only one which has been approved for sinus, which is dupilumab. The problem with it is it's very expensive. And in the US, in Canada, when I was there, we were doing the study for dupilumab for another company, and it was costing us. It was almost about $8,000 per shot. Which is, the government, the government of Canada refused to make it a part of their treatment plan. That's how expensive it was even for them, because there is a public healthcare system.
Yeah.
So
there's no private.
Yeah. At least in India, it's going to take some time for it to come. And the other issue with biologics is it's a lifelong thing. It's like having diabetes. You have to continue taking it every 28 days. You have to take a shot. And if we think that, biologic agents are free of any side effects, it's not true. Because I've seen patients in Canada who were on biologics, and there is very specific criteria to put a patient on biologics now. And they should have failed steroids for us to put them on biologics. That is a requisite in every, even in the UK where NHS was funding it, it was a requisite that you have to have 3 doctors approve this. Then only the patient goes on biologics.
And also the adequate course of steroids to be taken.
Absolutely. So they even check for compliance. So they check for compliance to make sure whether you've taken it correctly or not, and if you failed, because they check your ACTH levels and all that.
Yeah, and UK is very fond of 3 doctors approving something.
Not just failed medical, but also failed surgical therapy. So only in re-revision surgeries then we'll go in. So now not Diplo, but we use omalizumab, which is approved in India. And got good results with that.
Okay, and the last one is medico-legal issues. There's a whole lot of young people who have not faced any medico-legal issues, but almost every senior surgeon has either had a medico-legal issue or has just avoided a medico-legal issue. So your thoughts on the matter, that if you have a patient who's going to go to court or you think he's going to go to court, how do you deal with it?
Ma'am, this is going to happen very, very soon. This is going to become a thing which is very common. And, I'll just share with you this thing that I found this very exciting. So when I was in UK and we were working with the NHS, so the hospital makes it mandatory that all ICU patients, when we go for rounds, a legal advisor will accompany us. So what they check is they will ask us, there is a risk profiling done for the patient, and they will advise us that this is what you need to inform the patient. So that
Gaurav, can I hold you up a minute? I'd like you to talk in the Indian scenario.
So in the Indian scenario, I think if you're talking about corporate hospitals, they do have legal teams right now. But if you've got a very good documentation, then you can avoid this scenario. If you still feel that the patient is going to be, a litigation risk, I think it's, if you've had any complications, it's better the more you counsel the patient, the lesser will be the chance of your patient going in for a litigation. And worst case scenario, now it's mandatory for every one of us to have, our insurance policy taken. If you're doing, yes, indemnity. So if you're doing something like skull base, 5 crores is the minimum that you should have as an indemnity amount to proceed.
Nishit?
So I think we go back to the informed consent, that if you have to have a good informed consent, even if you think you're doing an AC polyp. Two, you have to be clear and honest with the patient if you had a complication. You have to tell the patient, I've had this complication, I'm doing my best, I have involved XYZ person also because I think their additional input will be beneficial. And you put it down on paper that I've had a CSF leak, I've done this repair. You be very clear in your documentation as well. For us, over so many years, we've had almost every possible complication. And some of my worst complications today are close friends. Only because they've seen that we've been sincere about our trying to handle their complications. We have not hidden it. The people who get into problem are the ones who try to hide it and run away from it, only for the patient to find out later, go to another doctor, and then, why didn't that guy tell us?
And also at the time of complication, how well have you communicated with them and relatives? They sometimes tend to nag you, but you need to keep your cool and still keep on explaining the same thing again and again and make them understand that you are doing your best and you are involving all experts around.
Yeah, I think patients read body language. No matter how educated or uneducated they are, they can read body language. And if they can sense integrity in what you're doing and saying, it will avoid. So written informed consent, no guarantees. Don't say 100% ye hoga, 100% theek hoga. No corridor consultation. So you may have given it as a casual advice, but the patient might take it seriously. So no corridor consultations. Honesty works best. Have you ever sixth sense that this patient may go in for litigation? Seek help before.
I think another important point is, ma'am, if you have problematic patients, if you suspect,
yes,
if you have that,
you will get that sixth sense.
And it's a complicated case where you have that kind of issues, it is better to video document your entire counseling process.
Absolutely, absolutely. If a patient asks you, if a patient asks you too many questions, you ask him, take a second opinion as well. In fact, that thing, take a second opinion should more likely come from you.
It's better you send him to somebody you know.
Yeah.
Or someone you don't like.
Or at least No. Send to someone whom you...
No.
Or you tell him, take a...
That is if you don't want to operate on that patient.
Yeah, send it to your enemy.
But if you want to operate, then send him to somebody you know.
And seek early legal counsel if there is a problem. So with that, thank you.
Thank
you. What we're going to do now, because of paucity of time and also, what is the time, Kshitij? 9:40, not too bad. So we are now going to invite the experts from all the centers one by one. And if they can give, we have 6 centers. So if each expert speaks for 5 minutes, it will be half an hour. But it will be well worth tapping into their experience. And if they have any specific points that we have missed or which they would like to emphasize, I would request each person to give their opinion. And we will go from center to center. Let's begin with Bangalore, Dr. Deepak Haldipur and Dr. Gayatri, if they are there. Open up Bangalore, please. I'm going to request you to sit here, if you don't mind. Yes?
Good evening, ma'am. It was an excellent program. My one question is that in CRS with polyp patients, because phenotyping would be very important because all polyps wouldn't behave in a similar way. How often a panelist would be taking help of a histopathology examinations? Is that what I
think Gaurav answered that question, but you can just repeat it.
Yeah, so we have this form which we fill out for, I mean, we've given it to our pathologist to fill out. So for every case, I think she works with me, so she knows this already, that every case of polyp, we do a biopsy and send it out. This is not to prove whether it's a tumor or not. This is to prognosticate the patient to understand, what is the tissue inflammation, what is the predominance, whether there's basement membrane thickening, any papillary change, any squamous metaplasia. These things you pick up and you start to prognosticate. In fact, we are going to publish a paper on this, what were our findings and how it correlates with post-operatively the way the sinus looks. So that's why we do it.
Do you have
only one concern that I had here was that because preoperatively, when you use steroids for 2 weeks' time, then your histopathology is going to be biased. You may not really get the true eosinophil count in that case.
Yeah, that's why we had mentioned that we have to do this before steroid administration. On the first appointment itself, if possible.
Yes. Anything else?
Maybe one thing that I wanted to add, ma'am, because I'm more of an allergologist, and from my perspective, is one other specific phenotype as an AERD, aspirin exacerbated respiratory disease. And you asked about a Montelukast. Probably AERD is a one condition where they also respond to Montelukast because they have a cyclooxygenase enzyme deficiency and their end product in their body is more of a leukotrienes. So this is one small category which would respond to Montelukast too.
Right. Thank you. That's good information. Any more things from your center, Bangalore?
Any questions? We had around 50 audience attending.
Thank you. Okay. Thank you very much.
We have a question.
Can we have Hyderabad?
Good evening, ma'am.
Good evening, madam.
Hello. We are coming in from Chennai here.
Okay.
Dr. Raghu here. Wonderful panel and a great program, ma'am. You covered all the aspects of rhinology from basic to advanced. So we have a question from one of our audience.
By any chance, I can work under
Dr. Raghunandan, could you take the question, repeat the question? We can't hear it from the
So see, there's Dr. Gayatri from here, and she's got a mic now. She can.
Hello, Gayatri.
Hello, I just wanted to just see you, and I think that's the only reason. That's the main reason that made me come to this hotel and attend this event and not watch it on the phone. So, it was just fantastic, I should say, the entire session. And I just heard one of the panelists saying that, giving steroids preoperatively may reduce the chance of reactive edema postoperatively. I've been seeing some patients, at least a significant number of patients whom I've been operating preoperatively, they have, even intraoperatively, there are no polypoidal changes in the sinuses. But postoperatively, say a week or so later, they start developing this polypoidal changes, and which persists for even a month or a month and a half. And I've been giving them postoperative oral steroids and subsequently tapering, starting on sprays, but they don't seem to be settling until for some, say, around 2 months, and automatically I can see after 2 months, then they start settling down. And they improve. Anything? Have you observed anything?
What you're saying is that they are resistant to steroids.
Yes,
in spite of giving them.
Maybe the dosing.
And they were not present at all preoperatively. These changes are only occurring postoperatively. Preoperatively, there were no polypoidal changes, whether in the CT or intraoperatively, what we could appreciate.
Anyone who's had that experience?
So if
the immediate post-op. Yeah, that you get little histamine release polyposis, is reactive polyposis. That will settle down by itself. It'll settle down.
So
you stay with your wash and spray, it'll settle down. Very rarely you need to give more oral steroids than what you normally do.
Does that answer your question?
Nothing harmful.
I was probably not aware of the condition before.
Okay.
I have a question to the panelists. What is their opinion about intrathecal fluorescein? Because sometimes we're having some suspected CSF leaks where we can't really identify the site. Do any of the panelists use that?
Yes, I think I'll take that. Now, when you have situations like where there is no active leak at the time of presentation, radiologically, you are not able to pinpoint or localize. You do your cystonogram, you do your MRI, you do your CT scans, and you're still not able to pinpoint. And we have had situations. Now, the advantage there is you can probably give the patient an option of getting an intrathecal fluorescein injected, and you can perform a Valsalva. And sometimes, and we have picked up cases like that.
And you need a blue filter for that.
Not necessarily, not necessary.
Not necessary.
Not necessary.
Also, if you are suspecting multiple leaks, then it makes a lot of sense. One patient that I operated on, she had 8 CSF leaks because she was a syndromic child who had traction done. So the whole skull base would become like a sieve actually.
No, the thing is, in post-traumatic leaks, again, when you have extensive skull base fractures, most of the times we would ask for a CT cystonogram. So generally, if there is an active leak, yes, you would be able to pinpoint where exactly the site is. But then again, when you have a situation where it is kind of masked or if it is not active at that particular point in time, this is one option that you have.
But a point of caution is that it's a very good medium for Pseudomonas to grow. So absolute aseptic precaution to be used while using fluorescent, and at times it can give you reaction in the form of convulsions.
Have any of you experienced that?
That is basically with the concentration.
Dose dependent. The higher the dose, the more the complication.
Right. So that's
Thank
excellent
you.
insights. Thank
Thanks,
you, Dr. Raghunandan. Thank you so much. Dr. Meghnad from Hyderabad.
Good evening, madam. It's a wonderful session. All of us have enjoyed. We are around 75 people here. I think somebody can enlighten us on the biofilms and their role in chronic sinusitis.
They are more resistant to management, and which is why we use certain surfactants like baby shampoo in certain resistant cases. So usually, I mean, of late now what I do is every case where I see some mucopurulent discharge, I do take a swab and see what it's growing. And that way I can sort of narrow down, you know, which antibiotic to give. So the resistance pattern has changed now for me at least. I did this mainly because now there's a recent study which proves that if excessive antibiotic consumption through the life of the patient can lead to cancer later on because of the change in the flora itself. So this is that is why if you observe nowadays we are seeing younger and younger people coming with malignancies. This is one of the causes as well. So that is what drove me to actually make this change where I take a swab whenever I see pus. I mean, it's nothing that you have to be so scared of that you have to start treatment today itself. You can wait for 2 days and start the right antibiotic at least. If you're suspecting biofilm, then yes, you can use a surfactant like baby shampoo to break that film and allow the antibiotic to penetrate into that space.
I think that's one of the reasons why I'm not a big fan of stents, either frontal sinus or even DCR stents.
Yeah.
And we do come across cases, you know, with persistent discharge, cavity discharging.
Yeah.
You know, in those kind of situations, something that has worked is for instead of your conventional saline douching, you can try tobramycin or amikacin. So these washes kind of are helpful in some of these refractory cases.
Tobramycin with amikacin.
Or amikacin.
Or amikacin.
Yeah.
Add into the wash.
Yeah.
The other out of the box things are colloidal silver, manuka honey, and what PJ is on a different trip with engineering bacteria to counter your biofilms, kind of set one enemy against another.
Okay, Dr. Meghnad, do you have anything to add? Any insights to this?
That's fine, madam.
Okay, anything else you would like to add?
Maybe quinolines and macrolides for a long term have some role against the biofilms.
Yes, so about a 6-month course.
Yeah, clarithromycin has been suggested in a 250 dose instead of a full 500 dose. But
50 OD. for non-IgE pathology, that is.
But I think more work has been done on Roxithro than Clarithro as yet.
Okay, thank you so much, Hyderabad. Let's go to Pune. Dr. Neelam Ved.
Good evening. Hi. Firstly, thanks a ton. I think today's evening was informative to say the least. It's been an eye-opener. Everything right from Nishit's talk to the panel discussion has been amazing. We've learned so much. I think the take-home messages were amazing, especially the stress on combined modality imaging, the fact that MRI is going to be the future, talking about, getting a learning curve on eggshell imaging, stepping out of one's comfort zone. I think what we really missed maybe in the imaging was addressing unilateral disease. Maybe the next time we can, focus on how would you approach the imaging of unilateral disease. One comment that came from one of our attendees today was when we look at the PNS, we are so focused on the sinuses. It would be good if we start looking at the alveolar margins. We are having a lot of cross references now that are coming from dentistry. So it would be a good thing if in our checklist, we also start looking at the alveolar margins. That's something that we have a tendency to overlook. We had a lot of discussion on, maybe not using contrast enhanced CT as a modality of choice. But I'd like to say here that you will have certain patients who are contradiction, they can't undergo MRI. Affordability sometimes becomes an issue. So in some cases, even though we do know that we want MRI with contrast, we may have to rely on using contrast enhanced CT. Renuka, especially we have that big discussion on doing nasal endoscopically pre-operatively. I think one point to be stressed there was a consent. Even if you're doing just a pre-operative DNE, there has to be a consent form for that, something which we overlook. Especially, I think Gaurav's points on consent, very interesting. I didn't know there were 6 points to that. And it would be nice if that's shared with us, just something that would increase.
Gaurav, that's for you. The 6 points that you mentioned.
Also, lastly, we did speak about the position. I just had a comment there when we talked about head extension. The point that Nishit mentioned is really apt, especially when you're operating on patients with, a high BMI. That extension really helps because the instrumentation really becomes a problem. I don't think, yes, we have Dr. Ahmad here who has a question. Can you give him a mic? Mic, please, to him.
Neelam, could you take the question and say it? It's better when you talk about it. It's better heard.
Be it in case of blockers or runners, be it allergic.
Doctor, could you please repeat the question from the beginning? We couldn't hear you.
I will repeat it, Renuka. I'm just waiting for him to tell me the question.
Okay.
Be it allergic or perineal rhinitis, what is the role of acetonide, transferon acetonide injection on the inferior terminates? Has anybody experienced on that? Because I've seen during my tenure in Bombay Hospital during LH time, some of our colleagues were using it and they had very good results. And somehow I tried it in Canada as well as in Pune. I have good results. What about the experience of our expert panel here?
Did you get that?
Yeah, we got it. Any experience any of the panel has on?
No experience.
No experience.
Okay.
How exactly is it given and how much?
It is 1 ampule to be taken in one in insulin syringe, and you give a xylocaine spray to the anterior end of inferior terminate and inject half of the half cc in one inferior terminate anterior end and half in the other one. And there were reports that there were some complications, but I have never inquired. At least I have done nearly about 30 cases, 300 cases so far, and none have inquired, and very good results.
Has there been a publication on this, or is it?
So far, there's no publication, but there were publications in the other journals itself regarding one complication was encountered among 1 lakh cases, but that is very negligible. But so far, I have not encountered it.
So how is that? That was very comprehensive, Neelam. Anything else to add?
Anyone else? Any questions? No, that's it.
Okay, thank you so much. We'll go to Delhi. Dr. Devinder Rai, we'd like your comments and any questions that you might have.
Hi. And
No, can we have Dr. Devinder Rai, please? We can't hear you as yet. In just a minute.
Can I be heard?
Yeah.
Hello. Hello.
Yeah, we can hear you now.
First of all, a lovely, and especially seeing you and Nishit and Dr. Hetal, of course, and the two other panelists, the young people coming into the field. Now, there was a comment from, or should I say an observation from my side and from our side over here, that a CT scan, when it is done, why do you think there's any role for a follow-up CT scan within a certain frame of time? Because I felt that was not highlighted. Because a CT scan being done just to, especially in the case of sinusitis, is something which is debatable because of the radiation thing. Second one was the maximal medical therapy. To my mind, again, it was not elaborated how much of steroid should be given earlier and when should it be thought of that this is the end of the maximal medical therapy. To my mind, just a week or 2 weeks of just giving steroid was not enough. There should have been a follow-up on that too. And you just...
Would you like to give us your opinion on this?
On the maximum...
Steroid therapy, yes.
Yeah. So, first of all, if there is a assessment by the end of, let's say, 3 weeks, 3 weeks of maximal medical therapy should be definitely given, which should have a tapering dose of steroids as well as an antibiotic and some nasal douches with let's say budesonide respule to be added to the nasal wash, or even the respule to be used as a nasal drop also, this which is what I've been doing nowadays. Now, if that after that there's a regression of the symptoms, it should be assessed by an endoscopy examination to see if there's any polypoidal mass or if there's a change in the middle turbinate, whether it's still polypoidal or not, whether there's some secretions there, and of course the symptoms. Because in an assessment, 50% of the decision for surgery is all based on symptoms also. And then the rest is a CT scan or a diagnostic nasal endoscopy. So we shouldn't ignore the symptoms also. Sometimes when we see that the polyps have regressed and they're just maybe in the middle meatus and the person is asymptomatic, should you again go for a surgery, or you can just keep the person on some kind of a nasal douche thereafter? So that's something, and I don't think every case of polyposis should be operated just like that. So that's what I think. And
right. Thank you.
I don't feel that a CT scan should be used for an assessment so fast. A decision of surgery should be really, really thought of.
Okay, thank you so much. Thank you. So have we finished all the centers?
Calcutta.
So sorry. Calcutta, Dr. Snehasis Burman.
Yeah.
Pleasure seeing you.
I want to thank Lupin for organizing such a program in a wonderful venue. And I want to thank you for planning this beautiful academic program. And I want to congratulate you for nicely executing the program. We have really enjoyed all the delegates in our Kolkata center, and I want to congratulate all the panelists. You have left no stone unturned. All the aspects have been covered. Ma'am, I want to clarify one thing. I have operated for a patient with chronic rhinosinusitis with nasal polyposis 10 years ago, where there is no mucosal disease on one side. So I have not touched on the healthy side and operated only on the diseased side. But after about 10 years after, she came back with disease on the other side. So what should we plan? Is there any experience of any panelist and what we should do?
Yeah, so this, especially in AFRS, is very often seen that the side which is operated stays normal, which actually confirms the fact that surgery is needed and that it has helped. And that side becomes normal when the opposite side. So it's the same factors which caused it on one side and now causing it on the other side. Essentially, poor ventilation of the sinuses. So the moment you ventilate the sinuses, that person has less chance of having AFRS as compared to the non-ventilated side. And yes, I've had that experience. I can see Gaurav nodding very vehemently. In fact, I can see most of the panelists nodding very vehemently. Hetal, would you like to give an opinion on that?
It is very common. Sometimes you really wonder whether it was the same side pathology or it is the operated, but the moment you see the scan, you know it that is the operated side, which is so clear. And it is all related to the immunology of the patient also, that though it was absolutely normal on that side, which over the years reacts in the almost similar way and gets the AFRS.
Yeah, but I don't think there is any role for proactively operating on the opposite side. So there's no prophylactic surgery of the opposite side to be done. It should be addressed only when there is disease in that side.
Because if there's a complication, nobody can save you.
Yes.
Yeah, so if you have a complication on that normal side, nobody can save you.
Yes, and also...
Well, nobody can save me. I want to put it as you. Yeah.
And also one thing I want to know from the panelists, you have said that in the post-operative period, you start douching with normal saline. Do you use topical steroid, and in what format? Is it commercially available nasal spray, topical spray, or you mixed steroid with the solution for douching? Ma'am, your voice is not coming.
Audience will get hungry.
Hello, can you hear me now?
Yeah. Yes,
okay.
ma'am.
Okay, so I use normal saline with 4 respules of Budacort in one unit of 1 pint of normal saline. Let's ask the panelists, what do they use?
Budesonide. Budesonide with normal saline, 2 respules.
2 respules in it. Okay.
Budesonide. Yeah, the wash.
Actually, it's the only proven approved drug for intranasal use right now in the wash form. That's why.
Yeah, so generally we start the budesonide washes almost maybe 3 weeks after surgery because we wait for all the clots to settle. Once the cavity is kind of cleared up, that is when we start the budesonide washes, not immediately after surgery.
Nishit?
Budesonide with nasoneb, like a nasal nebulizer for patients with resistant polyps.
Hetal?
Only in the wash form.
Only in the wash form. Does that answer your question, Snehasis?
Yes, thank you, ma'am.
Anything else?
Oh, thank you. No, ma'am.
Thank you so much. Thank you so much. And I'd like to take this occasion to call for a close on this program for more important matters to come. And thank you once again, all my talkative panelists. Dr. Gaurav Medikari, Dr. Vivek Sasindran, Dr. Nishit Shah, and Dr. Hetal Patel. Thank you so much for being part of this.
Thank you. Most of it.
Hello. Yeah, good evening, doctors. So I, Dhiren Kumar Panda, the NSM of Lupin Limited, so would like to thank each one of you for providing your valuable time and taking out of your time, especially on weekend, and making this ENT life a great and interactive one. I would like to thank Dr. Professor Renuka Brado for making this ENT life a lively one. Thank you, ma'am, very much. So I would like to request. I would like to also thank Dr. Nishit Saha for wonderful deliberations. I would like to thank Dr. Vivek Sasindran. I would like to thank Dr. Professor Hetal Patel. I also would thank Dr. Gaurav Medikari. Thank you, sir, for the active and interactive session. And also, I got this opportunity to thank each and every speaker, the delegates, the panelists across all the 6 centers, Kolkata, Pune, Delhi, Chennai, Bangalore, and Hyderabad. And I also got this privilege to thank the audiovisual. So without them, actually, this program could not be a great success. I also like to thank all the hotels, all the venues, the hotels of all the venues for making the beautiful arrangements. I also like to thank all my Lupin colleagues, so present in this hall as well as across all the centers and across in all the fields. So for this beautiful invitation and making this program a great success. So thank you very much. And I would like to request, please have your dinner. And thanks a lot. Thank you, ma'am, so for giving this opportunity. And would like to have this program in future also. Thank you, ma'am.